Good morning, everybody, and welcome back to the 8th Toronto Symposium. We've got an exciting program for you today. I'd just like to start by reminding everybody about the poll everywhere system that we're using for cases where the presenters will introduce questions during their presentations, and we'll be thrilled if the delegates would enter their answers to the questions, and we'll be able to show the answers live. This is the QR code you can scan. We'll also put the link up in the chat, and we'll show it as we come to each case, so that you can connect to the application and enter your answer. And then also just to mention that the sessions are all being recorded. So for any who are joining us today who weren't able to catch the sessions yesterday, you'll be able to you'll be sent a copy of the whole symposium. And we will also be working with our partners at the Congenital Heart Academy to put a version of the meeting onto YouTube through the CHA website. Okay, so without further ado, I'd like to introduce the moderators, or turn it over to the moderators for the next session, and look forward to a great day.
Great, thank you. Good morning, everybody. I'm Danielle Massarella, and I'm pleased to be here with Dr. Rachel Wald as your moderators for this morning, the first session of the day, which will be focusing on heart failure and pregnancy. I think we're going to start off first with an interesting case, and I think just in general, we'll try to save most of our questions is based on the time that we have available this morning for the end of the session, but if possible, we'll try to sprinkle them in as we go along. So now I'd like to introduce first Beatrice Fernandez Campos, who is an adult congenital heart disease fellow at the Toronto ACHD program right now at Toronto General. She's an adult cardiologist and echocardiographer, originally coming from Mexico City, and she's here to take us through our first case. So over to you, Betty.
Hello, everyone. Thank you for the presentation, and I'm going to start with the case entitled "When Severe TR Gets in the Way." So this is a 34-year-old female. She was diagnosed with cytosolitis dextrocardia, as we can see in the chest X-ray, and a congenitally corrected transposition of the great arteries with an ASD. She was diagnosed at birth, and she underwent an ASD closure when she was 5 years old. She had regular follow-up in her local cardiology hospital, and she was then followed up in her adulthood in a local ACHD center, and she was diagnosed with asymptomatic severe Tricuspid Regurgitation with moderate right ventricular systolic dysfunction. She was then referred to our center for assessment, to our ACHD heart failure clinic for assessment of a heart transplantation. On the first clinical assessment, she had basically no limitations during her normal daily activities. She could climb 4 or 5 flights of stairs. She even played competitive pickleball for 2 hours every Wednesday, and she was with no medications. She was basically asymptomatic with a functional class of the New York Heart Association 1. She even had 2 uneventful pregnancies, one in 2013 and the other one in 2016. With no complications. On the physical exam, it was notable for a normal blood pressure, normal heart rate. There was some RV heave and a 3 out of 6 holosystolic murmur in the right lower sternal border. No signs of heart failure. The ECG was in normal sinus rhythm at 72 beats per minute. There were normal intervals and a normal QR restoration, and it was suggestive of right ventricular hypertrophy. We did some blood work on her first assessment, and the BNP was normal. The transthoracic echocardiogram done that date of her first visit showed AV and BA discordance as expected, and there was a dilated systemic right ventricle with mild systolic dysfunction, low normal to mild systolic dysfunction. And there was a thickened tricuspid valve, as we can see here, very thickened, and severe tricuspid regurgitation with very dilated left atrium. There was also a normal subpulmonic or left ventricular size and function, and some trivial subpulmonic AV valve regurgitation. So as I told you, she had no medical treatment, and with this regard, although the evidence is limited to a few clinical trials and studies with a reduced sample and different types of intervention and also different types of diagnosis, based on our findings, we decided to start medical treatment with valsartan, 40 milligrams BID, and we suggested further investigations to evaluate the functional capacity of her patient, including a cardiopulmonary stress test that unfortunately she could not do because she lives 3 hours away from here. But we requested a cardiac MRI, which she managed to do. And here we can see the findings correlate with our transthoracic echocardiogram findings. There was a systemic, dilated systemic right ventricle, and with mild systolic dysfunction. There was severe TR and dilated left atrium, as we can see here in the 4-chamber and the 3-chamber view. The function of the subpulmonic left ventricle was normal, mildly reduced with an LVF of 51%, and that there was dilation of the subaortic right ventricle with a right ventricle and diastolic volume index of 123 milliliters over square meter, but there was a stable global systolic mild systolic dysfunction with an RVF of 44% and a moderate to severe tricuspid regurgitation with a regurgitation fraction of 35%. We also requested some invasive hemodynamics. There was normal pressures in the right atrium with 0 to 1 millimeters of mercury and an LV systolic pressure of 22/1. The mean pulmonary artery pressure was 5 millimeters of mercury and the wedge pressure was 4. There were also normal saturations and a cardiac output of 3.7 liters per minute. So in summary, right now we have a 34-year-old female with a CCTGA that has asymptomatic severe tricuspid regurgitation, dilatation of the systemic right ventricle with a right ventricle and diastolic volume of 123 milliliters over square meter, and a mild systolic dysfunction with an RVF of 44% and normal pulmonary artery pressure. And the first question to the audience would be, what would you do with this patient? Would you obtitrate the medical therapy? She's only with valsartan 40 milligrams BID. Would you refer the patient for a tricuspid valve replacement? Would you refer the patient or assess the patient if you have it in your center for heart transplant? Would you discontinue the medical therapy and just continue clinical monitoring, or you would do none of the above? We have here the QR for the poll everywhere.
Sorry, just 1 second.
Yeah.
Okay. Back to you.
Well, we refer the patient for a tricuspid valve replacement, and we presented her case in a clinical conference, and she was accepted for a tricuspid valve replacement. And as we can see, the AHA guidelines, they recommend a tricuspid valve replacement with a recommendation to A, level of evidence at C, in asymptomatic adults with a CCTGA that have dilatation and or mild dysfunction of the systemic right ventricle. And also the Canadian guidelines from this year, 2022, they also recommend for patients with systemic right ventricular dilatation or systemic mild systemic dysfunction, tricuspid valve replacement. So in regards to the tricuspid valve replacement, the evidence for this recommendations come from two studies made on the Mayo Clinic. The one dates from 1995, and they evaluated 40 patients with CCTGA, and they overall they showed like a right ventricular ejection fraction of more than 44% was a predictor of survival, post-operative survival. And they did a retrospective study in 2011, again in the Mayo Clinic, that also showed that an RVF of equal or more than 40% and left ventricular systolic pressure of less than 50 millimeters per meter of mercury were predictors of survival in long term. So our patient underwent a tricuspid valve replacement. She had a 33 millimeter St. mechanical valve. And during the surgery, there was detected a small ventricular septal defect, which they closed. And she had no complications, no postoperative complications, and she was discharged on the postoperative day 6. Now the patient comes 10 months post-surgery. She is asymptomatic. She has much more energy than before, and she is really, really active. This was demonstrated by her pulmonary stress test. This was a Bruce protocol and a treadmill. She exercised for 6 minutes. She had a normal heart rate response, a normal blood pressure response, and this was a maximal study by RER of 1.28. And she had mild limitation with a peak VO2 of 19.5 milliliters, which was 75% of predicted for women of her age and her body type. And the VO2 at anaerobic threshold was 16 milliliters, which was 72% predicted. And she had a normal oxygen pulse of 10 milliliters per beat, which was 90% of predicted. This is the transthoracic echocardiogram done on the follow-up appointment. And we can see the systemic right ventricle is still mildly dilated and has mild systolic dysfunction. The tricuspid valve was normal functioning. It had a peak gradient of 5 and mean gradient of 2, and the left ventricle had a normal function, with no evidence of left ventricular outflow tract obstruction or no pulmonary valve stenosis. And there was a small residual VSD with a peak velocity of 4.3 meters per second. We also requested a cardiac MRI that, as we can see here, the right ventricle and diastolic volume index for her body surface area went from 123 milliliters pre-TDR to 90 milliliters over square meter post-TDR. The RV ejection fraction remained the same from 44% to 46%, and the left ventricular ejection fraction went from 51% improved to 59%. And we have here the images for the cardiac MRI, which show a interval reduction on the size of the systemic right ventricle and mild systolic dysfunction. Then we have our mechanical tricuspid valve there, and Wilson valve, and the reduction also in the size of the left atrium. We can see here again the interval reduction on the size of the right ventricle and a mild systolic dysfunction. And the patient, she wants to have another pregnancy. She feels so well. So she wants to be pregnant again. What would be your advice in this case? Is pregnancy contraindicated? Is pregnancy considered a high risk? Is a pregnancy considered a low risk because the systemic right ventricle function is only mildly impaired, or we cannot stratify this patient without repeating the hemodynamic assessment? We have again the QR code there. Okay. Okay, yes. So in fact, we know that, thank you for the poll. We know that the pregnancy in this patient, it's a high-risk pregnancy. She's a patient with, as I've been telling you, CCTGA, has a systemic right ventricle that has mild systolic dysfunction. And in addition, she now has a mechanical valve and she requires anticoagulation with vitamin K antagonist. So the question is, how do we stratify this patient? And there are several ways of doing it. We could start with some risk scores, which are mathematically driven, and they include multiple variables on them. Or we could also stratify according to the specific lesion. For example, stratifying according to a systemic right ventricle, or in this case, stratifying according to the mechanical valve that the patient has. And the corporate risk score is a mathematically driven score that has all these predictors. It was especially designed for patients with heart conditions. And it gives us several risk factors. It's a weighted score. And we can see in the axis here, we have the points, which is from 0, 1, 2 points, 3 points, 4 points, or more than 4 points, which will give you the higher risk of complications, right? So in the y-axis, we have the risk of cardiac complications. And in this case, our patient has a mechanical valve and also has ventricular dysfunction. So she will be having 5 points, which will stratify our patient in this category, which is more than 4 points. And it's a risk, she has a risk of 45 to 50% risk of complications during her pregnancy. And this is a meta-analysis from the Suicide Al. It was published in 2017, and it's a contemporary meta-analysis with anticoagulation in pregnancy. And patients that have a vitamin K antagonist treatment, they have a lower risk of mortality, like 0.1% when compared to using low molecular weight heparin or unfractionated heparin. And they have also lower risk of thromboembolism with a 2.7 risk compared to low molecular weight that have 8.7 risk, or unfractionated heparin 11.2% of risk. But using vitamin K antagonist brings you risks of having warfarin embryopathy, and using low molecular weight heparin, well, it reduces your risk of having this embryopathy. So overall, I would say that my conclusions to this case, it would be that all of our patients required individualized decision-making, and they required a proper risk assessment in a specialized ACHD and heart failure clinic for heart transplant assessment, or advanced heart failure therapies, and cardiobstetric units for assessing their risk, pre-pregnancy risk. And we should use all our different tools, evaluate the overall risks according to the resources you have, and obviously stratify according to all of these resources. Thank you.
Great, thank you, Betty. That was a great case. I have one question for you. The Q&A right now is empty, but I was wondering if you saw this patient yourself, and if you could give us any insights about how her personal goals and potential pregnancy sort of factored into the timing decision-making when it came to the TBR.
Well, initially, she said she didn't want a pregnancy before having the mechanical valve. This was discussed with her, and she felt she was satisfied with her family. But when she felt that she was getting better, she had less symptoms, and she was really, really active, then she decided she wanted another one. And then that's where you have to properly counsel your patients again and just weight her new risk factors.
Thank you. So I think now we can move on to the second of our speakers. It is Dr. Raphael Alonso Gonzalez. I'm happy to introduce him. He's the current director of our center here at the Toronto ACHD program. He completed his specialist cardiology training initially in Spain and his ACHD fellowship at the Royal Brompton Hospital in London, UK. From 2009 to 2011. And then in 2012, he began working at the Royal Brompton as a consultant cardiologist in ACHD and pulmonary hypertension. He was the director of the ACHD inpatient services while he was there, and also established their heart failure unit. He joined our unit in 2018, where he's now also the fellowship director. He'll be discussing mechanisms of heart failure and drug therapy in systemic RV physiology for us. Thank you, Rafa. Over to you.
Thank you, Danielle, for the kind introduction. Let me get my slides up. Start. Okay, so thank you again, Danielle, for the kind introduction, and thank you to the organizers for inviting me to be here to talk about a topic that I love, and it's challenging, but I really like it. I hope that in the next 40 minutes we can share some light in this topic. So we're going to talk now in this session about mechanisms of heart failure and medical treatment in systemic right ventricle. Have no conflict of interest to declare. So the objectives over the last 30 to 40 minutes is to discuss first, which is the natural history of the CCTGA patients, what are the mechanisms of adaptation, and more just what is the mechanism of failure of the systemic right ventricle. And in the end, we will touch upon what evidence we have on medical therapy in this population. So I think that we, as an introduction, we have heard this several times during these 2 days of a fantastic conference, that CCTGA is a rare condition, and that's why we need formulas like this. It's only 1% of infants born with congenital heart disease. Most of the cases will have an associated lesion, being an Epstein-like tricuspid valve, the most common associated lesion, and 20% of the patients will have a dextrocardia. As you know, 2% they have a risk of having a complete heart block of 2% per year. But if we look at what happened to this population with regarding their ventricular function, this is a very interesting study published by Vanderbilt, and looking at 192 patients from 19 different institutions in the US. And they look at what are the predictors of developing heart failure and what happened to the systemic right ventricle over time. And you can see here that at the age of 40, around 40% of patients will have at least some degree of systemic ventricular function. This is more prominent in patients with associated lesions, which is the lower line, than in patients with non-associated lesions, but this also will have some degree of systemic RV dysfunction. But interestingly, also we can see that this population over time, mainly those with associated lesions, will also develop subpulmonary LV dysfunction. Sorry. When we look at the risk of heart failure in this population, up to 60% of the patients by the age of 45 will have had at least one episode of heart failure, and this is more prevalent in those with associated lesions, but patients with non-associated lesion will also develop heart failure. Why heart failure and systemic RV dysfunction is important in this population? Because we know that having a systemic RV dysfunction actually worsens your prognosis and increases this study from the Mayo Clinic, and they showed that having a systemic RV dysfunction increases your risk of sudden cardiac death and ventricular arrhythmias. Actually, if we look at what is the cause of death of patients with CCTGA, and this is a nice study looking at different cause of death within the different congenital heart disease. If we look at the congenital heart disease, the CCTGA here, we see that heart failure and sudden cardiac death are the most common cause of death in this population. So we have a population that is going to has a systemic ventricle, a systemic right ventricle in systemic position that we know that's going to fail, and this patient is gonna develop heart failure. But the question here is how this ventricle fails, and I think to understand how the ventricle fails, we need to understand how the ventricle adapts first. So we know, and it was a fantastic session yesterday by Andy Reddington, which I'm not gonna repeat what he said, but we know that the right ventricle structurally is different. There is a ventricle has only 2 layers against compared to the 3 layers that they have the systemic right ventricle. However, we know that when systemic right ventricle when the right ventricle is in systemic position, actually anatomically adapts to that position and develop that 3rd layer, mimicking a left ventricle. So we have an adaptation from the anatomical point of view that try to mimic a left ventricle when the right ventricle is in systemic position. But not only that, the right ventricle also has the ability to adapt functionally. This is a very nice study done by Andy Reddington when he was at the Bronton, that he looked at pressure and volume curves in patients with volume-loaded and pressure-loaded ventricles. So on the left, we have a patient with a fallot, and on the right, we have a patient with severe pulmonary stenosis. And as you can see in the pressure volume curve of the patients with a fallot is more like a patient with an RV, with lack of isovolumetric and isovolumetric contraction time and isovolumetric relaxation time. This is the typical RV curve. But when you have a pressure-loaded ventricle, and this is just in a PS, you can see how the pressure and volume curve is more likely to be like a left curve, which to have a proper isovolumetric contraction time and isovolumetric relaxation time. But if we look at how the systemic RV adapts, I think one of the most beautiful studies that has been done to prove how the systemic ventricle adapts is this study, which is already 15 years old, in which where the authors use a strain to see what actually how is the contraction pattern of the systemic right ventricle compared to a normal RV, a normal LV. As you can see here, in a normal right ventricle, the ventricle has three different contraction patterns, but you have in this one they only look at the longitudinal strain and the circumferential strain. And in a normal right ventricle, the longitudinal strain is the main driver of the contraction, opposed to what's happening in a normal left ventricle, where the circumferential strain is the main driver of the contraction. When they did this in a systemic right ventricle, you can see that actually the circumferential strain takes over, and this is the main driver of the contraction in this patient. So it's another way of proving that the systemic ventricle, the right ventricle in systemic position, adapts to the function of being a systemic ventricle. What the ventricle doesn't get is the apical twist. You know that in a normal LV we have that apical twist that is an important contributor to the systolic function. The systemic RV is not able to get that apical twist, which is going to have an effect in the function of the ventricle later on. So we know that over time, the problem is this ventricle adapts physiologically, adapts anatomically, but is not made to last long in systemic position. And over time, we know that the ventricle is going to fail. And one of the biggest challenges that we have in congenital heart disease is to assess the function of the systemic right ventricle. If you have an MRI, of course, MRI is the gold standard for assessing systemic ventricular function, but unfortunately, it's not a test that we can do every day, and in a day-to-day practice, what we use is echo. Sorry, I don't know why my video stopped. What we use normally is echocardiography, and all of you that do echocardiography in systemic RVs, you know that you can use TAPSE, you can use the fractional area change, you can use a SPRIME, but in the end, all of us end up to assess the function by eyeballing. And it's quite difficult to differentiate year by year whether the ventricle is deteriorating or not, and it's impossible to get subtle differences. So I think that we have to move on from assessing the ventricle in our overall function, and actually, if we want to understand how this ventricle fails, we need to look at the ventricle as how every component, how the different fibers of the endocardium, of the midwall, or the epicardium contribute to the contraction of the ventricle. If you have a fancy 3D software, you can do that, but actually that's not available to everyone. But what's a technique that is available almost in every single lab nowadays is a strain rate. And we know that with the strain rate, we are able to assess the ventricle in a more detail the pattern of contraction rather than the global contraction of the ventricle. Why Cdls is important? I think over the last, I would say, 5 to 10 years, the GLS has been having a huge amount of publications of the use of GLS in congenital heart disease, and I think that is come from, and we're trying to get tools to assess our patients. This is a recent study from the Mayo Clinic that they look at 186 patients with CCTGA, and they showed that actually over time, the GLS reduces the same way that reduces the fractional area change. But when we look at what predicts survival in these patients, they actually prove that neither the TAPSE nor the fractional area change, neither the TAPSE nor the end-diastolic area was a parameter for predicting outcomes, nor the fractional area change. Only the GLS was able to predict outcome in this population. So we have a tool that reduces over time and predicts outcome. We already knew something this because it was published by the group in Holland in the 2 years before. This Canadian Journal of Canadian Journal of Cardiology paper that they actually went beyond the use of GLS. Of course, they demonstrate that GLS predicts outcome, but also they saw what GLS contributes to your MRI to predict the outcome of your patients. So here, what I find very interesting in this study, in patients that have a deteriorating ejection fraction by MRI with 30%, those that have a GLS, a worse GLS was more than minus 10 was the cutoff they got in this study. Those with worse GLS had a worse outcome than those with the same ejection fraction but have a good GLS. So proving that actually this is a typo in the graph. So proving that actually GLS adds on to your or to predict the prediction of the prognosis of our population. Another problem we're going to have over time in these patients is that is the developing of tricuspid valve regurgitation, as Betty showed in her case, and so was this discussion, which is first the egg of the chicken, or the chicken, if it's the tricuspid valve fails first, or the ventricle fails first, and after the tricuspid valve becomes incompetent. I think majority of us agrees that in these patients, that 90% of them will have a Epstein-like type of valve, and probably is the valve the one that fails first. We're not going to discuss here whether or not we should change this valve. But as Betty already showed in her case, that having a tricuspid valve regurgitation is bad in your patients. But whether the question is if it's bad because of itself having tricuspid valve regurgitation, or as many of us believe, is what is the prognosis depends, or it's worse because of the impact that the tricuspid regurgitation has on the ventricle. The ventricle is going to dilate further, and is going to change this pattern of contraction that we saw, and that's going to end having a systemic RV dysfunction, and that is going to determine the prognosis. And actually, in that study that I showed before from the group in Holland, in the Netherlands, they showed that actually it's having a severe tricuspid regurgitation and a GLS more than minus 10.5 were the only independent predictors of outcome in this population. So Tricuspid valve regurgitation is another mechanism of failure, but actually what is going to lead is a deterioration of your ventricular function in your pattern of contraction. But if we really want to understand the right ventricle, of course, we agree that this is a structure that is different from the embryological point of view, from the anatomical point of view we have discussed, is different, is able to adapt in systemic position. But what is very interesting of the right ventricle is how it adapts to a pressure overload situation. This slide is very busy. I know I'm going to pretend to go through it, but I think it's a slide important to understand why this ventricle is different. So if we compare how the pressure overload ventricle adapts to failure with how the left ventricle adapts to failure, we can see that the pressure overload right ventricle has less ability to produce energy when the left ventricle fails. Activates mechanisms to produce more energy in the myocytes. That doesn't happen in a pressure overload ventricle. Has another interesting factor that they do not activate the antioxidant enzymes, and as you know, the antioxidant enzymes are the responsible for protecting the ventricle against apoptosis, which is going to be an important factor in a pressure overload right ventricle. And of course, there's going to be a mismatch between the demand and the perfusion, and that is happening because of the coronary distribution. But on top of that, they have less ability of increasing the angiogenesis, and therefore going to have more risk of ischemia. But what I think is the most interesting factor in patients with failing right ventricle is that how the ventricle reacts or adapts to the angiotensin signaling. So what happened is there's been a lot of studies looking at the distribution of the AT2 and AT1 receptors in the heart, and since that majority of them conclude that actually the distribution is the same in your RV or your LV. But what happened in the failing pressure overload right ventricle, the angiotensin signaling pathway is then regulated instead of being upregulated, which is what happened when you have a systemic LV failure. And on top of it, there is a higher metabolic inactivation of ACE inhibitors in patients with pressure overload right ventricle. And this probably might explain why many of the drugs that we have been using might not have worked in the studies we have done. So this brings to us a massive challenge in terms of treating these patients, because we have a ventricle that is in systemic position. We know the ventricle adapts. We know the ventricle adapts both functionally and anatomically, but we know that it's set up for failure and it's going to fail at some point. And many of these patients will end up with a heart transplant, but in the middle, all of us want to offer them something to see whether we can help them or not. And in the next 10 minutes, I'm going to spend time to discuss medication in these patients. So, of course, when you are an adult cardiologist and you treat heart failure and you have a guideline like this, where you have a massive amount of tons of medications that have proven already to increase survival in this population, you are very happy. And in congenital heart disease, we have been trying to mimic what we have in acquired heart disease for many years. And this is a different table, but summarizes the same studies that Betty presented in her presentation. And over the years, we have failed to prove with any study that actually these medications work, apart from one study that David mentioned yesterday in his case in the morning, that is a longitudinal study with valsartan for follow patients with systemic right ventricle, a mix with DDTA and LTGA. And they follow them for 8 years, and they showed that in those with symptoms, this medication reduced MACE, but didn't reduce mortality itself. In a most recent study, that's what I call real life or real world study, which study done by two institutions in Europe, the Pompidou in Paris and the Royal Brompton in London. They look at their population with systemic RVs, which was 359 patients. Majority of them were patients with mastum or shunnering. Patients were actually relatively asymptomatic, so quite good, and followed by 7 years with 40% of them on ACE or ARB or on ARNI, and they showed that treatment with ACE inhibitors was not associated with reduction in heart failure or mortality in this population. And as conclusion of all these papers, we have so far concluded that medication do not work in this population. But I want to go back and do a little bit of an exercise looking at these studies with a little bit of more detail or with a critical point of view. So every time that we want to justify medication in why these studies fail to prove that the benefit, we always focus on the numbers. I'm not going to focus on the numbers today because I think that's something we won't be able to resolve. This is a niche population, and therefore the numbers are going to be always low. But I want to focus in what kind of patients we have been including in these studies. If you look at the functional class, majority of patients included in these studies were patients asymptomatic. That's a problem because if we just go back to the old studies in acquired heart disease where ACE inhibitors proved to increase survival, actually the ACE inhibitors only work in symptomatic patients. So we've been trying to treat patients asymptomatic, and we've been trying to treat patients with a quite good ejection fraction of the systemic RV. So if your patient is asymptomatic and the ejection fraction is good, you might not be able to show improvement. But I think one of the biggest challenges of these studies is what kind of the weak endpoints we have tried to demonstrate, like change in volumes, which is the most common endpoint used in these studies, and improvement on exercise capacity, which is a good endpoint. But if you are already not symptomatic and you have a good ejection fraction, your exercise capacity might not change. But I think one of the biggest problems of these studies, and the biggest in my opinion, is we have to do it. We have to mix DDT, the masters and sennins with CCTGAs, but actually from the physiological point of view, these are two completely different circulations or different physiologies, which can explain why some of these patients might not respond to medical therapy. And this was proven in one of my favorite studies in physiology in systemic right ventricle, which was done already in 2008, where the authors here got a group of patients with systemic RV, and they look at how patients with CCTGA and patients with TGA respond in terms of increasing cardiac index after giving them dobutamine. Of course, if you give dobutamine to CCTGAs or to patients with an atrial switch, both of them going to increase the cardiac index. But when they look at how they increase cardiac index, so whereas both of them were able to increase heart rate, only patients with CCTGA were able to increase stroke volume. Why this concept is important is because every time that you give an afterload reduction to anybody, doesn't matter what anatomy you have, you're going to have the way that the body increases you drop the cardiac output, you drop the SVR, and the only way of keeping up with the cardiac output is increasing stroke volume. So if you don't have that ability, which is what happened in patients with atrial switch, you actually, afterload reduction medication actually might reduce the cardiac output. But in patients with CCTGA, we do not have this problem. And if we treat these patients, actually, we might be successful in getting a good outcome with these patients. But if we treat these patients, we have to keep this in mind. I said before that if you have a failure in a systemic, in a pressure overload ventricle, you have a downregulation of your angiotensin pathway and a higher metabolic inactivation of ACE inhibition. What this means is that you might have to treat this patient with a higher dose that you would normally do in a normal, or the higher dose, not you would normally do in systemic left ventricle, but with the higher tolerated dose for the patients. And in my practice, I always try, every time I treat these patients, I try to get them to the maximum dose of the drug. As I have some patients in which actually the systemic RV improved, and a couple of patients only where the TR reduces. So the key point here is to understand how the ventricle fell to be able to apply and how the ventricle works to be able to apply that to our medical therapy. Another way of failing of these patients is the increase of fibrosis, which is a problem in systemic LV as well. When I was at the Brompton, we look at our 55 patients with systemic RV, and this is a mix of atrial switch and CCTGAs, and we saw that those patients that have a higher burden of gadolinium, which is a marker of fibrosis in the systemic RV, they have a higher risk of arrhythmia and heart failure and hospitalization. So, and over time, they have a much worse prognosis and fibrosis was better marker for prognosis than the peak VO2 in these patients. In an attempt to when we think about fibrosis and medical therapy, we always think about mineralocorticoid inhibition. And in an attempt to prove this point, the group from Barcelona tried to recruit their systemic RV patients and give them a propranolol. Unfortunately, they only could recruit 27 of their patients, and in the sample size they needed 110. So this study, the primary endpoint was negative. But what I find very interesting in this study, despite of having only 27 patients and having them with a very good ejection fraction, and they proved in a secondary endpoint that those patients that have had a pleuronol, which is what they use in this study, have a reduction in the fibrosis markers in peripheral blood, which doesn't say much, but is probably a very good hypothesis generation, an interesting concept that mineralocorticoid inhibition might help to reduce fibrosis and might help to reduce also the myocardial fibrosis and improve outcome. But we haven't proved that. Of course, recently we have a new drug, which is not that recent anymore, it's just from 2014, to the armamentarium of treatment in patients with systemic left ventricle. We have Entresto, which was a massive advance in heart failure, because it was many years without having a drug that improved survival in this population. So it was made it to the news very quickly. And we know that Entresto improves survival in patients with systemic left ventricle. In congenital heart disease, every time we have a new drug in acquired heart failure, we want to see what happened in our population. And since then, we had 4 studies that have or 4 centers. It's just a case series that have published their experience with this drug. I think the first 3 studies are not, we cannot draw a conclusion because they reported both systemic RV, systemic LV, and even univentricular hearts. But I think I want just to draw your attention to the last study, which is not CCTGA, but it's DTGA. It's a very well-designed study. It's a study from the Netherlands and sorry, from Belgium, and they got the 20 patients with DTGA. All of them, they did in mixed populations. All of them with significant RV dysfunction. Majority of them symptomatic. Follow them for 6 months, and they showed that this patient had an improvement in the NT-proBNP, an improvement in the systemic right ventricular function, again measured by GLS, by global longitudinal strain. They didn't have any change in functional class, but they had improvement in quality of life. So I think that if this happened to patients with atrial switch, this might be a promising result for patients with CCTGA. More recently, we have a new group of drugs in patients with heart failure, which is the Sdl D2 inhibitors. As you know, the Sdl D2 inhibitors were developed as anti-diabetic drugs, and during the observational, but actually the monitoring period after the drug was approved, you have to have a period to monitor the drug in the real life. The real life, actually, they have a lot of cardiovascular effects, and now it's becoming a drug more for heart failure than for diabetes. And What we have learned over time, and the more we know about these drugs, the more I believe that the Sdl D2 inhibitors are the aspirin of the 21st century. And the more we know about them, we know that they don't just act on the pancreas, but also have a significant beneficial effect on the kidneys, on the liver, on the brain, peripherally, and of course, on the heart. I'm not going to go through that table to describe what they do in the heart, because the more we know, the more impressive it is what these drugs can do in the heart. But to summarize, what I think is key within the congenital heart disease patients is these drugs have an ability to decrease the renin-angiotensin activation, an ability to decrease the activation of the sympathetic nervous system, which is something what we only can do with beta blockers, and we are talking about a population with a high risk of complete heart block, where beta blockers might be limited to be used. They halt the pressure overload induced myocardial fibrosis, which is, I think, I find it a fantastic mechanism for patients with systemic right ventricle. They have an effect on the reverse cardiac remodeling. And one of the things that I find more interesting of these drugs for this population, they improve myocardial energetics. I'm not going to go through how they do it, but if you're interested, this is a very good review to read about how this drug works. But how the way they do it is at a mitochondrial level in the myocyte, which in a patient with systemic RV that has no ability to increase the energy of the myocyte, these drugs might be a good option. And of course, another factor that might not be as interesting for CCTGAs, but for other populations in congenital heart disease, like the single ventricles, we know that the glucoresis mediated by these drugs results in a greater reduction of interstitial fluid compared with other diuretic agents. So they don't actually deplete the patient intravascularly, but have a higher effect on your interstitial fluid, which is also very interesting in a mechanism for congenital heart disease. We don't have much data, or we don't have any data in congenital heart disease, but recently, it was a couple of months ago, it's been published the first case report with this drug in congenital heart disease, which happened to be a patient with CCTGA. So this is a patient, a 20 years old female, born with CCTGA, pacemaker for AV block, upgrade to CRTP, TBR, upgrade to CRTD, thrombosis of TBR, initiation of sacubitril valsartan. She did not tolerate the drug, another TBR thrombosis, and after she started a period of multiple admissions for heart failure. So the authors, and I spoke to the first author about the case, and they decided just, well, try, see what happens if we give them this patient Sdl D2 inhibitors. They had tried everything, and that was the only option that they hadn't tried. And surprisingly, 4 months after, the patient improved functional class from having 4 admissions in the previous 6 months. She only had 1 admission for heart failure in the following 4 months. When they look at the systemic ventricular function, again, using global longitudinal strain, the function improved. And more interestingly, the exercise capacity measured objectively with peak VO2 increased significantly from 33% of predicted to 56% of predicted, which I think is it's just one single case report. We cannot say that these drugs work, but I think if we look at the mechanisms of action of these drugs and we understand the physiology of the systemic RV, I think these drugs can be very promising drugs for this population. I don't want to finish without mention something about Pda5 inhibitors. I'm going to bring a paper that is very old, but I think this paper has been was published, and I'm not sure that the scientific community has paid much attention to what I think is one of the most interesting papers published in the last 15 years. So the authors in this paper, they have samples for patients after heart transplant and they look at the Pda5 expression in patients with normal LV, with normal RV, with LVH, and with RVH. And they prove that if you have LVH, and more interestingly, if you have RVH, you increase the Pda5 expression in your myocytes. And when they they developed a rat model that they created an RVH model. They got a myocyte and they put the myocyte in a dish, and they measure what happened with the contractility of the cell when you give this to the myocyte when you add Pda5 inhibitors. And what you can see here is that this is with no Pda5 inhibitors, and this is when they gave sildenafil, and you can see how the contractility, the electrical activity of the cell, which is the expression of the contractility, increases when you give Pda5 inhibitors to the hypertrophied cell of the RV. And more interestingly, they went on and looked at what happened to the myocyte in the electronic microscope. And you can see here that in patients without RVH, they did not have any change in the length of the myocyte when they give sildenafil. However, patients with RVH, and when they add sildenafil to the sample, they have a significant change in the shortening of the myocytes, which indicates that these drugs might work, increasing contractility in the systemic RVs with patients with RVH, which have not been proven. But I find this paper a very interesting concept that we have not tried in this population. However, we have currently a study that has been already recruiting for several years, where they pretend to the sample size was they wanted to achieve was 98 patients, and they've been recruiting since 2017. This study has not been published because mainly for the follow-up, they want to follow up the patients for 3 years. The endpoint is change in RV and systolic volume, which might not be the more accurate endpoint, but they look at also a change in ejection fraction, exercise capacity, and what happened to the neurohormonal activation. And I think that I'm really interested and looking forward to knowing the results of this study. So to conclude, I think we can tell that the systemic right ventricle is physiologically similar to a systemic left ventricle, that progressive systemic ventricular dysfunction and tricuspid regurgitation are the main mechanisms of systemic right ventricular failure, that there is significant maladaptation of the right ventricle to pressure overload with a higher metabolic inactivation of ACE inhibitors, which we have to consider if we decided to treat these patients. Fibrosis in the systemic right ventricle relates to the new onset of atrial tachycardia and heart failure, and we don't know whether or not mineralocorticoids inhibitors might have a role in reducing fibrosis in these patients. And the last thing is we know that the Pda5 is upregulated in hypertrophied right ventricle and probably should be one of the routes for research in the future if we want to help this population. Thank you very much.
Thank you very much, Rafa. That was comprehensive, elegant, and very thoughtful. We're going to hold questions until the end, but you're encouraged to enter them into the chat. So we'll move on to the next speaker. I'm very excited to introduce Dr. Canada Silversides. Dr. Silversides is a professor of medicine at the University of Toronto, and she holds the chair in pregnancy and heart disease at the Sdl Heart Centre at Mount Sinai Hospital. There, she leads the obstetric medicine program and is the director of the cardio-obstetric clinic. She's the inaugural editor-in-chief of ACC's newest journal, JACC Advances, which I think you might see a slide for at the end. She also works at the PMCC, and she specializes in ACHD and ECHO, and is the vice president at CatchNet. Dr. Silversides' research interests include pregnancy and heart disease and ACHD. She's also contributed to many international practice guidelines and consensus statements. So I'm very much looking forward to your talk, Candace. I always learn something from you, and we'll now turn the floor over to Candace to hear about management of pregnancy in CCTGA.
Excellent. Thanks a lot, Rachel, and thanks for everybody for being here. Are you able to see my slides properly? Perfect. Okay.
Yeah.
So I'm going to be talking about pregnancy, and I think you may ask, why is that relevant for you, some in the crowd? I do want to draw to your attention, there's been a few recent AHA statements that are trying to highlight that pregnancy is an important aspect of care of the cardiac patient. A recent AHA statement suggested that a general understanding of cardiovascular disease in pregnancy is really core knowledge for all cardiovascular physicians. But beyond that, and more relevant to us in the field of congenital heart disease, there's a similar AHA statement, again, this one focused on congenital heart disease, that says all women of reproductive age with congenital heart disease should be counseled about pregnancy earlier in their medical care by their care team, and by a care team that has some knowledge of pregnancy and the risks it incurs. And that should be done at an age-appropriate time, soon or after sexual maturity. So it really falls in the hands of both the pediatric community and the pediatric congenital community and the ACHD community. So I do think it's relevant for us that we have some working knowledge of what pregnancy risk incurs for patients. And so I thought I would just start with a case where we think about what we might need to know. This is a patient born with CCTGA, VSD, and subpulmonary stenosis. She had a VSD closure and resection of the subpulmonary stenosis and insertion of an LV to PA conduit when she was 4. Then at age 14, it was discovered the LV to PA conduit was severely stenotic, discovered on a CT scan. But the native LV outflow tract was patent, and so no interventions were done. And so now you have either an asymptomatic teen, if she was seen by you in a pediatric clinic, or a young woman of childbearing age, who I would see in my clinic, this actually was when I saw her, with CCTGA, VSD, and subpulmonic stenosis. She has moderate subaortic RV dilation at this point in time, but with normal systolic function. She has moderate to severe tricuspid regurgitation, and the LV to PA conduit is, as I described earlier, stenotic, but with a patent native outflow tract. So the question here, similar to the question you had from Dr. Fernandez earlier, is what would you consider her pregnancy risk? So again, if you were to discuss it with her in clinic, or even touch on it without going into detail, would you tell her her risk is prohibitively high, really high, not that high? So I would consider her intermediate risk. And in fact, you know, she did have a pregnancy. She did well throughout pregnancy without any complications, but had an extreme premature delivery at 31 weeks gestation. So what I'm going to do today is two things. I want to discuss pregnancy risks and give you some tools for thinking about how you might stratify risk in the pregnant population with CCTGA. So although pregnancy is one aspect of a woman's life, you do have to consider what happens before and what will happen after pregnancy when you think about how you're going to counsel these women and how you're going to risk stratify them. So obviously we heard about this all day yesterday. You know, it's a very heterogeneous population. Some women will have unrepaired CCTGA and have a subaortic RV. Some will have a physiologic repair, but no matter what the type of repair they have, they will still be left with a subaortic RV. The double switches have not really made it to childbearing age yet, where there's any significant body of literature yet for us to understand how they're doing. And obviously some will be more extreme forms and have single ventricles. But I'm going to talk about the literature about what we know in the cohort we have currently, which is mostly physiologically repaired CCTGA. But beyond the type of anatomic repair they may or may not have, they also may have residual subaortic RV dysfunction. We've heard lots about this, including Rapha's great talk. They may or may not have TR, or they may have had a tricuspid valve replacement, like the case you heard this morning. They may have conduit obstruction to various degrees, and they may have heart blocker arrhythmias. And all these factors are important when thinking about pregnancy risks. And then beyond the heart, they also may have non-cardiac comorbidities. Nowadays, with advancing maternal age, they may have acquired conditions like hypertension and diabetes, which have important implications, and they may have psychosocial issues that are important to consider for pregnancy. So all those factors are important when you're thinking about the physiologic stress of pregnancy. which includes an increase in plasma volume, so an increase in preload, an increase in heart load or in heart rate, and an increase in cardiac output. Obviously, that's problematic for women with ventricular dysfunction or significant outflow tract obstruction on the left side. It's also a prothrombotic state, which is important for women who've had arrhythmias, who are prone to thromboembolism for other reasons, or who have a mechanical valve, again, like the case you heard earlier. It's a proarrhythmic state, so for women with arrhythmias, pregnancy can be problematic, and there are bleeding tendencies. So if women are cyanotic, they're more inclined to bleed, or if they're on anticoagulants, as examples. So you can imagine there is a possibility that you can decompensate in pregnancy. And beyond that, there is also the fact that you may decompensate in pregnancy or early after, and that may impact your ability to look after your newborn or your children when they're younger. And finally, all those variables considered can change your life expectancy. So this is a study looking at mortality in different subgroups of patients with congenital heart disease compared to an age-matched population. And if you look at, say, a 30-year-old with an ASD has a mortality equivalent to a 32-year-old in a normal population. But if you look down this chart to the patients with subaortic RVs, they have a mortality that's equivalent to a 51-year-old. So life expectancy and early mortality is important if you're thinking about having a family, and that has to be factored into this risk to pregnancy risk assessment. So for pregnancy risk, I'm going to talk about it a bit. I'm going to mostly focus on maternal cardiac risk, but there also is important fetal and neonatal risk, as I highlighted in my case by the woman that delivered with extreme prematurity at 31 weeks. So the early two studies came out in the late 90s, just before 2000. This was the first study. It was by Heidi Conley and Carol Warrens at Mayo Clinic. This is the first big study. They reported on 60 pregnancies. 11 ended up with miscarriage or unsuccessful, but there were 50 live births in this series. They had various types of repairs. 7 had VSD closures, 5 had conduits. There were 2 with mechanical tricuspid valves and 1 with a pacemaker. But what you can see, despite that kind of complex CCTGA population, is that there were no maternal deaths. Only 2 of the 50 pregnancies were complicated by heart failure. 1 occurred in a woman with AV valve regurg and an EF of 45%, who then went on to have her AV valve replaced. And the other woman actually had 12 pregnancies, and there's various complications, but including heart failure, endocarditis, and an MI. And then 1 woman developed hypertension. But compared to other complex forms of congenital heart disease, in fact, this cohort of women does relatively well. So the study that came out at the same time by Judith Terrian and Jane Somerville tried to stratify it a bit, and they looked at 2 different cohorts of CCTGA patients, those with really kind of clean CCTGA without major associated lesions, and those with more significant associated lesions with VSD and subpulmonary outflow tract obstruction. And just a few differences about that era of CCTGA women and also these 2 groups is, first of all, those women with without associated lesions were more likely to be NYHA class 1 before pregnancy. 50% of their women with complex lesions had cyanosis, so a bit different than what we would typically see today in the physiologically repaired young women. And you can see only 18% of the VSD-PS women had repairs. So again, not exactly what we would see in a current era, but despite that, still most women did well. There was no maternal deaths. Only 3 women developed heart failure. One occurred in the setting of worsening subaortic RV dysfunction. 1 had worsening subaortic RV dysfunction and AV valve regurg, and 1 had AFib and stenotic left-sided AV valve disease. Then 1 woman had worsening cyanosis and 1 had a CVA. But again, relatively good outcomes compared to many other complex conditions. What also is, I think, somewhat interesting is when you look at the outcomes in the 2 groups, there wasn't a major difference between the simple CCTGAs and the more complex. But clearly, we all know that there are women who are at higher risk. I'm going to come to that in a moment. But just to give you kind of a summary slide that maybe is a reasonable take-home slide, this was a summary of the literature up until 2007. So it included those 2 early series and a few others. And when they looked at kind of a summary data of what was happening, they found that 4% of pregnancies in this cohort of women, so all comers, all different types of CCTGA, plus or minus or repairs, arrhythmias occurred in about 4% of pregnancies, and heart failure occurred in about 7% of pregnancies. And there's subsequent studies, and it tends to lie around these numbers. So that's typically the risks, we would say, for all comers with CCTGA. But as I mentioned, I think there is women that are higher risk. And so what do we know about those? Well, this is a more recent study, and it's from the ROPEC investigators, where they looked at 162 women with subaortic RVs. And you've already seen this slide yesterday, but in this cohort, 41 women had CCTGA. And they found two predictors of adverse outcomes: women who had signs of heart failure before they got pregnant, and also women who had systemic RV dysfunction, less than 40%, were more inclined to have maternal cardiac complications during pregnancy compared to those who didn't have those two variables. So how about the tricuspid regurgitation? Well, we don't have any studies that have looked at that specific modifier and how it predicts outcomes, although you see in some of the cases, clearly the heart failure occurred in women with TR. But we do have this study, which we published from Toronto, where we looked at 430 pregnancies in women with moderate or severe regurgitation. It included many women with congenital heart disease, and many of the women with significant TR actually had CCTGA. But what you can see is, if you look on the x-axis, you see the different type of regurg, and on the y-axis, you'll see the complication rates, and you can see the groups with either MR, AV valve regurg with either MR or TR, or with multi-valve regurg, were at more risk of developing complications, in the range of 15% for women with TR, and in the range of almost double that at almost 30% if they had multi-valve disease. But what's interesting, we teased that out a little bit, and we found actually that it wasn't just the regurg that seemed to be associated with the dysfunction. It was regurg plus other features. So we found some high risk features. If women had had heart failure before they got pregnant, if they had, I wish I would have written systemic or subaortic ventricular dysfunction, but we wrote left ventricular dysfunction, but it really represents subaortic RVs in here as well. And if they had pulmonary hypertension. If you had any of those three high risk features, your chance of getting into trouble in pregnancy was 32%, compared to the women that had none of them, the risk was only 6%. So again, it's not just about the regurg, but it's regurg plus other variables. Now, you've seen this slide as well. This is a large study of almost 2,000 women with pre-existing heart disease, many with congenital heart disease, but we tried to find out what are the main drivers of adverse outcomes in everybody. And we found, I think, some helpful risk modifiers that are important to consider as well. So as you've heard from the case that was reported earlier, this is a 10-point risk score. It's mathematically derived. It's a weighted risk score, and there's 10 different predictors of adverse outcomes. On the x-axis, what you can see is the different risk scores. You tally up the points depending how many of these baseline variables you have. And on the y-axis, you see the rates of cardiac complications, which are primarily heart failure and arrhythmias, but the rates of those cardiac complications during pregnancy. And obviously, the more points you get, the more likely you are to run into trouble. But as it relates to CCTGA, we see that women who've had heart failure before they got pregnant, similar to the study I just showed you, are more inclined to have complications. If you have baseline poor functional class or cyanosis, you're more inclined to get into trouble in pregnancy. If you have ventricular dysfunction or pulmonary hypertension, again, your rates will be higher. And finally, as you saw earlier, if you have a mechanical valve, you're a high-risk pregnancy, no matter what you do. But I think looking at some of those general risk prediction tools are helpful, because although we may not have some of the nuanced information in CCTGA because the studies are small, I think some of these big risk prediction models are helpful, and we superimpose it on what we know about CCTGA. So in summary, there are some high-risk features. I've talked about those and I've listed them here. I think the main two high-risk features, though, that really drive outcomes are ventricular dysfunction and pulmonary hypertension. And I think that's supported by the ESC guidelines on pregnancy and heart disease. This was a consensus statement. It's called the WHO classification, and many pregnancy experts got together and classified those lesions according to whether they thought they were low, intermediate, or very high risk, like the table I'm showing you here, which shows lesions that experts felt were so high risk that pregnancy was in fact contraindicated. And what you can see is the first and the second cardiac diagnosis listed in this classification are pulmonary hypertension and systemic RV with moderate or severely decreased ventricular function. So I do think those are the main drivers of adverse outcome, but as I've been highlighting, it is complex. Now, there's one other issue as it relates to pregnancy, which is this issue of what pregnancy does to the woman and her ventricle over the long term. And this was the first study that started to highlight this issue. It was an issue looking at women with subaortic right ventricles, but really in the setting of mustard operation, although we've kind of taken this concept and run with it with CCTGA as well, although we really don't have the data. But in women who have subaortic RVs, this study looked at what happened to their ventricle in terms of the RV size, the RV function, and also they looked at what happened to TR during pregnancy. So if you look at the blue box here, and you can see my cursor, this woman here that I've highlighted she had absent RV systolic dysfunction before she got pregnant. When she was pregnant, she had moderate or moderate dysfunction. And then after pregnancy, by the end of pregnancy, she had severe systolic dysfunction. And the same thing happened with the size of the right ventricle in some patients, and the same thing happened with degree of TR. So in summary, in this study, there were 28 pregnancies, 31% had progressive RV dilation. But what I think is really important is 25% had progressive RV dysfunction. And of those, in the subsequent few years after pregnancy, 75% had no recovery. So some women bounce back, but many don't. And then if you look at the degree of TR, 50% had progressive TR. And of those, 38% didn't have recovery in the years after pregnancy. Now, it is really hard without a control group to know if this is related to the natural history, where we know these things happen over time, or it is really the pregnancy is responsible for all of that. But it certainly has raised a lot of talk about whether pregnancy accelerates this trajectory. I don't think the jury's out. There's different studies, there's different conclusions. The studies are small, there's lots of limitations, but I think it is something we think about. Now, that's the maternal risks. I'm only going to show you one risk as it relates to fetal and neonatal risk, but I do want to highlight that if moms don't do well, babies don't do well. And certainly there's other factors as well, because in this study, looking at women with subaortic RVs, including those with CCTGA, and comparing it to controls, you can see that in this study, they found that neonatal complications, which were primarily prematurity and low birth weight, but it occurred in 63% of pregnancies in women with subaortic RVs compared to 17% of controls. And the graphic on the right side of the screen shows you the birth weight in women with subaortic RVs. Those are the blue bars compared to those with controls. The birth weight centiles are on the axis. You can obviously see all the women with subaortic RVs have small babies with birth weights much, much lower than the control group. So what do we do with all this information? Well, I've showed you this slide earlier, but we are obliged to think about pregnancy risk to make sure that teens and women are educated about what that means for them and what the risk would be should they get pregnant, so they can make informed decisions. And that's in a number of guidelines that have come out in the last 5 years. So this is an AHA scientific statement, but it's come out in a number of sets of guidelines. The guidelines that I'm showing you here actually are guidelines that pertain to caring for patients with congenital heart disease. But they also do say that in that discussion, you should also include the possibility that pregnancy may contribute to a decline that may be irreversible, and that you should touch on that. I think you have to do that with some knowledge that we don't have excellent data on it, but it could happen and it is a possibility. For those women that do get pregnant, beyond just this issue of how do you decide who's high risk, You have to decide what type of surveillance they will need, what kind of imaging, both for the mom and the baby, maybe the placenta. You might need antenatal testing. If they run into complications, you need to figure out how to treat them. You need to figure out how to deliver and what to do after they deliver. These are many issues. I'm not going to go into them, but it tells you the complexity that you would need to care for these women once they do get pregnant. And to do that, you really need a multidisciplinary team. So the team is called the cardiobstetric team. Again, it's all over the literature now. It primarily includes MFMs, cardiologists, cardiac anesthetists, and nurses that are kind of the core of the team. But then there's many other team members that really are needed to deliver care in these complex patients. And so it is important, and the guidelines now say, a number of sets of guidelines will tell you, if you have women with intermediate or high risk congenital lesions, they should get care in one of these cardiobstetric centers. And this is our cardiobstetric team at Mount Sinai Hospital and affiliated with Toronto General Hospital in Toronto. You really do need to put these teams together to provide care to these complex patients. So in summary, women with CCTGA are at risk for heart failure and arrhythmias, although the risk may be lower than expected compared to other complex lesions. However, there are some high-risk features that should alert you to women that would be at more high risk for pregnancy complications. Teens and women should receive preconception counseling, and it should begin early. And for those that do become pregnant, they should be referred to a center that has expertise in congenital heart disease and pregnancy. So thank you very much. And I think Rachel mentioned, but I just wanted to highlight, there is a new JACC sister journal. It's called JACC Advances. I'm the editor-in-chief, and we are focusing on congenital heart disease, ACHD, cardiobstetrics as part of our focus. I hope you think about it if you have any interesting research in these fields. So thank you very much. And I look forward to our questions.
Candace, thank you very much. That was wonderful and practical with lots of clinical pearls. So I enjoyed that. I don't see any questions yet in the chat for this talk. I'd like to start with one. Candace, if you have the luxury of having a patient come for preconceptual counseling with a systemic RV, CCTGA, do you use cross-sectional imaging like MRI to get your RVEF? And how do you incorporate that into your risk stratification? Do you have a threshold of 40% or 30%, or do you look beyond that in terms of counseling preconceptually for risk?
Yeah, so absolutely great point, Rachel, highlighting how we best image these women. But these women absolutely need MRIs for really a nuanced look at their subaortic RV to find out what the RV function is. Also to look for other anatomic lesions, some of which maybe you could correct before pregnancy if you thought they would contribute to the pregnancy risk. So I didn't get into that, but it is also important when you see them, if they're thinking of a pregnancy, how you can optimize them. And optimizing also includes optimizing medications, because there are some medications, again, I couldn't go through everything, but medications that may need to be modified if they're potentially teratogenic. So I do think an MRI is really fundamental to that risk stratification and understanding the anatomy and the subaortic RV. I mean, the guidelines say if you have an RV less than 30%, you're really high risk and you should avoid pregnancy. I think the data doesn't tell us the exact number. So anything less than 40%, I do start to get worried about that the ventricle either will decline or the women will have heart failure and clinically decline. But I can't tell you that there's any data about the exact sweet spot. You saw the echo study said less than 40%, but that is one study, and I do think you have to incorporate all the different variables, because I don't think it's just simply the EF that dictates the outcomes in these patients.
Fair. Thank you, Candace. So we have two questions for Rafa. The first is, great talk as usual, as a comment. In your practice, which anti-failure medications would you use in a patient with CCTGA and a failing RV? That's the first part. And when would you initiate treatment? Do you start when the patient's symptomatic or when the RV hits a threshold?
So that's a very interesting question. I don't know if I know the answer. I can just share with you what I do. I definitely, if a patient is symptomatic and patients with CCTGA, I treat them with afterload reduction. For after many years and debating which patients might benefit the most, I find I use a cutoff of MRI less than 40% of treating patients asymptomatic. In terms of what I use as a medication, I start these patients I personally use valsartan, but the reason I use valsartan is because of the study I showed you before that is the only one that long term might have more benefit, but I'm not sure that we have it's not a drug effect. So I think that I would suggest your personal preference. In terms of what other medication I use, over time, I stopped using beta blockers as a primary prevention for these patients. I think that the evidence is much lower. You have a risk of complete heart block, and I don't use beta blockers unless the patient has arrhythmias. If I'm gonna start somebody on medication, after I try to get them on a maximal dose of maximum tolerated dose of valsartan. A majority of my CCTGAs are on 160 BID, and actually you have to wait. It takes up to a year for some ventricles. Some of them don't improve, and the idea what I discussed with the patients is you are not using this for increasing survival or improving your ventricle, which is not what the data show, but might reduce the rate of deterioration of the ventricle. So I made that very clear. I think you have to discuss with the patients when you are not using a medication that is tons of data. I'm very honest with them, and my intention is to reduce the rate of deterioration, and takes up to a year in some ventricle to see some improvement. In every patient I use ACE inhibitors. When I get to the maximum dose, I use a eplerenone. I get them to 50. And if the patient is asymptomatic, I stop there. If the patient has symptoms, then I switch them to Entresto. And the Sdl D2 inhibitors, the problem in Canada is that they are not covered by OHIP, which is our insurance. And if the patient has coverage, them if the patient has very severe ventricular dysfunction and symptomatic, I try. But as so far I've managed to use only in 2 patients, so I don't have much to share with you yet. And you shouldn't forget that if patient is very symptomatic and and those that are mainly pacemaker dependent, CRT is an option that always have to use it. You can use in this population. But that's more or less is the order where I do things and how my brain works, which I'm not sure that is the right thing, but that's what I offer to the patients. But you always have to discuss with them that what you are doing is trying to reduce the rate of deterioration, and the data is weak. And some patients say no. So, but those that accept, I treat them.
Thank you. There's another question. I think you've answered it, which was when you start ARBs, beta blockers, MRA, or Sdl D2 inhibitors. So you've addressed that. I actually have a question. You focus in on our sickest patients in the heart failure clinic, and I'm wondering if you can share with the audience when you like to see referrals made to the heart failure service in terms of, are there thresholds, or is there something that you'd like to see in terms of how sick patients are or how well they are? Do you like to meet them?
I think that's a very good question. So I think the easy answer to that is every patient that you feel uncomfortable treating should be referred to the heart failure clinic, at least for assessment. That's a good starting point, because sometimes, we see them and we might find something to do or nothing and send them back. But definitely any patient that has had at least one heart failure admission, one heart failure decompensation, and I strongly believe that patients with severe TR and systemic RV should be seen in a heart failure clinic. I don't say that we want to offer them anything at the beginning, but in the end, as I said, I did a talk about medical therapy, and I use medical therapy, but this medical therapy does not increase survival in this population. And in the end, they're going to need a heart transplant, and having a relationship with a heart failure clinic where also we have more ability to see them more often actually might keep them more compensated, and also develop that long-term relationship that you need with a patient before referring the patient for a transplant assessment. So as soon as you think that you are uncomfortable, and any patient with a heart failure decompensation or severe TR and bad ventricle should be seen in a heart failure.
Okay, thank you. That's very helpful. We have another question that's coming for Candace. It's related to progressive systemic RV failure in pregnancy. Are there any predictors of progressive dysfunction?
Yeah, there is no study that clearly identifies what's driving it all, but I would envision the worse your RV dysfunction is, the less able you are to handle the hemodynamic load of pregnancy. So you have less reserve, so you could tip a little easier. And I think probably having the double hit of a bad ventricle and severe tricuspid regurgitation with superimposed increased preload from pregnancy probably accelerates it, but we don't have a good, clear understanding of what causes some women to deteriorate. And furthermore, we don't have a good, clear understanding of why someone deteriorate but bounce back once the hemodynamic load is gone, and other women just never bounce back. So no, but if you could solve that in the next decade, it would be a great advance. So whoever asked the question, that sounds like a fantastic research.
A research project, exactly.
Yeah.
There are no other. I have a question actually for Betty. It's related to the case. I don't know if I heard correctly, but in the beginning of your case, did you mention that this patient was referred for transplant assessments, and that's how the patient came to PMCC? And if
Yes.
if that was the case, I was just wondering what, through the talk, there are some reassuring findings in terms of asymptomatic status, normal BNP, and I was just wondering what the criteria were that led to the referral. Why was somebody out there considering transplant?
Did you want me to take it?
Yeah, you can take it now.
So Betty didn't see this patient. So this patient was referred to my clinic actually, and the referral was for that. Was the patient came thinking that she was coming to a transplant assessment. She was told in another unit that she couldn't have a tricuspid valve replacement. She had some symptoms according with the referral that she was symptomatic, which we didn't prove in our clinic that she was, and she thought that the only option she had was a heart transplant, and came referred for transplant assessment. And when we had the discussion about TBR at the first appointment, she was a little bit shocked because she was told, she had been told for 3 years since the TR had been worsening over the last 3 years, and she had been told that she couldn't have more babies, she couldn't have a TBR, and she would develop heart failure and would die in the near future. That's how the patient came to the clinic with that concept from another clinic, which is another example why these patients should be referred to a heart failure clinic, coming to your question without telling them anything, because I think it's better to refer for assessment than just took a while to convince her that actually a valve was an option, after being told for 3 years that a valve never would be an option in her life.
Okay, thank you. That provides the context. Actually, Rafa, the next question is for you, and it will probably be our last question. I don't know if we didn't have the full 20 minutes. I don't know if we can stay, have a panel stay on a little bit longer if there are more questions, but this will be the last in the official session. The question is about heart rate stabilization. Do you have any experience using ivabradine or digoxin in failing systemic RV management?
That's a great question. So I'm a fan of ivabradine. So I've been using ivabradine since I was a resident, because we had it available in Spain by then already. I don't want to say how long ago, because that makes me old. But I'm a fan of ivabradine. I became less a fan of digoxin as time goes by. So I don't use digoxin even in systemic left ventricle. I think it's a drug that is an old-fashioned. The DITCH study was good at that point, but we have better treatment these days. Ivabradine is a drug that I haven't used it in systemic RV, but it's a rationality behind that. If you know the study that made ivabradine a heart failure drug, is the beautiful study where you can the drug was beneficial in those patients that after using beta blockers, your heart rate was above 70. I think the ivabradine has something else than this beyond heart rate, why that works. I don't believe that just reducing your heart rate below 70 improves your outcome, but that's what the study said. I think that in terms of heart rate is never a problem in systemic ARI. So there's unlikely to have your patients tachycardic. So I never use it. I don't think it might be a role in this. I use that drug a lot in systemic left ventricle failure in specific cases, and I think it's a great drug when the patients have severe LV dysfunction and they are very tachycardic. But tachycardia is no problem in this population, so it's not a drug that normally is I use. I never use it in this population. I don't think there is a much role for it, but I don't have experience personally.
Okay, so I think we're going to close right on time. It's just at 10:35. But if you want to put questions in the chat, I think the panelists can directly answer questions. I think one more has just come in. So thank you very much for an excellent session. And we'll close now and go on to the coffee break. Thanks, everybody.
Coming back for the next session at 10:55 Toronto time. Thank you.
Thank you, everyone.
Nice seeing you, Rachel. I guess I'll see you soon.
I'll see you next week, Candace.
Yeah. Boy, it's flown by. Can't believe it.
It's flown by for me first. Yeah, the year went by very quickly. How are things on your end?
Well, you know.
Sorry to interrupt, guys. So we are still live, so audience can hear the conversation. Just letting you know. Yeah, thank you so much.
Nice to see everybody. Okay, bye-bye.
Good morning, everyone. Welcome to the second session this morning on devices, VAD, and advanced care. I'm Anica Bulic, a pediatric electrophysiologist here at SickKids, and it's my absolute pleasure to co-moderate this session with my two colleagues, Dr. Amar Jiwa, heart function and transplant specialist, and Dr. Alex Flo, cardiac intensivist here at SickKids. We have a very exciting group of speakers this morning. We're very much looking forward to hearing their insights and approaches to managing this very vulnerable and complex patient population. We'll go ahead and get started with a case presentation by our very own Dr. Anya Lynch. Dr. Anya Lynch is finishing up her heart function and transplant fellowship here at SickKids, and will transition to a research role as the BMS Canadian Heart Failure Transformation Alliance Fellow in July. She holds a medical degree at the University College Dublin. She completed her pediatric training with the Royal College of Physicians of Ireland, followed by cardiology fellowship at SickKids, and was one of our outstanding chief fellows. Anya, we look forward to your case presentation.
Thank you, Dr. Bulic. I'm just going to share my screen.
Got it.
Excellent. So good morning, everyone. As Dr. Beatrice has spoken to you, I'm one of the heart function fellows here at SickKids, and I'm going to talk through one of our more interesting and complicated cases of congenitally corrected transposition of the great arteries. And similarly to the other case presentations, for those of you who've been logged on for the past day, we'll use the Poll Everywhere app to give everyone the opportunity to contribute opinions regarding management decisions. So the link will be in the chat, or you can scan the QR code, which I'll add to all of the question slides. And if anyone has additional questions, please ask them in the chat and we can review during the discussion session at the end of our session. So our patient was actually diagnosed in infancy, but was presented at cardiosurgical conference at 4 years of age. So that's the point I'm going to begin at for discussion around management options. At this time, she was well grown at 15 kilos and her saturations were 97%. She did have a history of SVT 2 years previously, but was well controlled on sotalol. This was her baseline chest X-ray at that point, as you can see, showing moderate cardiomegaly with enlarged central pulmonary arteries and increased pulmonary vascularity. And I'm not going to show you her full first study, but this was our subcostal sweep showing aorta anterior and left of PA, as you can see, and that large muscular VSD that extended from inlet to outlet. There was no obvious straddle and there was good biventricular function at that point. And it's going to be important at later points in the story, but it was noted that her pulmonary valve was dysplastic and doming during opening, as you can see on the image on your left. There was a little bit of deviation of her outlet septum with flow acceleration in the pulmonary outflow tract. And the gradient on this echo was 65 millimeters of mercury, but this is in the context of a significant left to right shunt through the VSD, which you can see. And this is her 4-chamber view showing that slightly tethered and apically displaced septal leaflet of her tricuspid valve, but she had no real tricuspid regurgitation at that point. And so we come to our first question. So given this information, what would you recommend as a next step at this point? As before, to vote, you can either scan the QR code, use the app or the website. So our options we felt were double switch, pulmonary artery banding, physiologic repair with closure of the VSD, or more investigations. Interesting evolution of responses. So I'll continue on with the story. So we actually discussed her at our cardiosurgical conference, and the decision was to proceed to MRI and cath to further evaluate her ventricular volumes, QPQS and PVRI. And you can see in these images that she has a severely dilated and mildly hypertrophic subpulmonary left ventricle with a borderline ejection fraction. She's also got moderate to severe right ventricular dilatation, also with a borderline ejection fraction, and I'll give you the numbers in a moment. This image probably gives you a better sense of the degree of dilation and dysfunction at that point. In terms of numbers, her left ventricular end diastolic volume was 170 mils per meter squared. Ejection fraction was 49%. Her LV mass was 78 milligrams per meter squared, or grams per meter squared, I should say. And her right ventricular end diastolic volume was 168 mils per meter squared with an ejection fraction of 45%. Her QP to QS at that point was 3.4:1. This was her cardiac catheterization data. So left ventricular systolic pressure was near systemic at 79, and her indexed PVRI was 0.6, so very low. So now I'm going to come back to my previous question to see if there's any change in the responses. Again, with consideration for double switch, pulmonary artery banding, physiologic repair with closure of the VSD. More investigations are continuing to follow.
Back to you.
I think that the variation in responses there probably reflects the challenges of this case, similar to the discussions that we had at the time. Moving forward, we actually did proceed to double switch in this case. And some of the aspects that fed into the decision making at the time was that she had no tricuspid regurg, which was obviously a benefit. She had reasonable biventricular function, considering we've already discussed this week that an ejection fraction of less than 45 or 40 certainly is associated with poor outcomes, but hers was higher than that. The subpulmonary left ventricle was generating systemic pressure, albeit in the context of high preload. The LV was hypertrophied, and obviously the PVRI was low. Potential concerns identified were that she had an abnormal pulmonary valve and above volume loaded subpulmonary LV, and therefore the outflow tract gradient across her pulmonary outflow tract was likely overestimated in that context. In any case, following repeat discussion, she proceeded to double switch with VSD closure. She weaned off pump without difficulty and chest was closed, and she returned to the cardiac critical care unit, paced for postoperative heart block on reasonable doses of inotropic support with epinephrine and milrinone at that time. However, her intraoperative transesophageal echo did show significant residual lesions in the form of moderate aortic incompetence and moderately reduced biventricular systolic function. And 2 days later, she remained marginal in the critical care unit, and you don't need me to tell you that her echo at this time showed severely reduced biventricular function, with mild tricuspid regurg and mild to moderate mitral regurgitation. Her left ventricular outflow tract at that time was unobstructed, but she had moderate neo-AI. And I haven't shown you, but her baffles were unobstructed. Clinically, she remained in a low cardiac output state despite maximal inotropic supports. She had progressive end organ injury over the following couple of days with acute kidney injury and hepatic dysfunction, and so a decision was made to proceed to coronary angiography. She unfortunately had a cardiac arrest on arrival in the catheterization lab with eCPR and was cannulated to VA ECMO. And I'm not going to go through this in too much detail, but this was her coronary angiogram on ECMO, demonstrating normal coronaries. She returned to the CCCU at that point, so she's now 3 days post-operatively and cannulated to VA ECMO. So the next question is, what would your next step in management be? Would you continue ECMO as a bridge to hopeful recovery? Transition to BiVAD as a bridge to transplant? Reverse or double switch? Reverse or double switch and band her pulmonary artery? Or recommend withdrawal of life-sustaining measures? So it sounds like most people are still optimistic for recovery at this point, probably more so than we were. But I will continue. 1 second, get my slides reopened. So it was an interesting discussion at the time. So I'm going to walk through the decision-making process. Ultimately, it was felt that her LV systolic dysfunction was more significant than would be expected, given that she had systemic pressure preoperatively. That her low cardiac output may relate to reduced preload post-VSD closure and mild to moderate neo-aortic incompetence, and that therefore her LV function was not likely to sustain cardiac output, and there was a low probability of further recovery on ECMO. So on the basis of this, we actually proceeded to reverse her double switch 7 days after her original procedure. She was subsequently PA banded prior to decannulation. The rationale for this being that her right ventricular function was severely reduced and there was severe TR at the time of the clamp trial prior to decannulation. So she was PA banded with a pressure gradient across the band of 20 just at the time of decannulation. And then decannulated with chest closure, as I said, 10 days after her original procedure. At this point, she still had significant residual lesions, this time in the form of severe TR and a dyskinetic septum. And this is what we were ultimately left with. So you can see significantly improved from the previous images I've shown you, but still at least mild to moderately reduced biventricular function. And again, in the short axis, and severe tricuspid regurgitation with some mild mitral regurgitation. She did, however, wean from inotropic supports at this time, but remained milrinone dependent. She was therefore assessed and listed for transplant prior to discharge in home milrinone. However, she continued to have an overall trajectory of worsening heart failure symptoms over the subsequent months. She had limited energy, static weight gain on high calorie energy feeds, as is demonstrated very clearly on her growth chart. She had atrial arrhythmias, which were extremely challenging to control, including flutter and AET, and needed escalating doses of milrinone. This was her chest X-ray prior to her most recent admission, demonstrating marked cardiomegaly. And you can see enlarged central pulmonary vascularity with pulmonary edema, and there's some retrocardiac atelectasis reflective of her left lower lobe collapse. So again, I'm going to pause briefly there for input as to what people feel the next step should be. Would you admit for optimization of medical management? Would you consider a systemic right ventricular assist device? Plan for a biventricular assist device from the outset? Recommend withdrawal of life-sustaining measures? A little bit of a preference for biventricular support as opposed to systemic right ventricular support. That might be center dependent, I guess, at this point. So we did admit and optimize her medical management insofar as was feasible, given that she was already on significant supports. And therefore ultimately proceeded with a systemic VAD implantation with a 15 mil Berlin heart with RV apex to aortic cannulation. She had an initial requirement for high right ventricular support with nitric, epinephrine and milrinone, but subsequently did wean from supports and transitioned to the ward about 1 month post-operatively. And her biggest issue at that point was challenging atrial arrhythmias. Sorry. And this is our patient now, 6 months post-VAD insertion. And you can see that she's demonstrated recovery of growth with appropriate decompression and improvement in cardiomegaly on chest X-ray. And just to demonstrate that despite her multiple failed attempts at biventricular repair, she actually has quite a good quality of life. So I'm going to pause there. I think we're moving on to the next speaker, but if there's questions in relation to the case, we can take them at the end of the session.
Thank you so much, Anya, for sharing that really interesting case. I think the fact that there is a split in approaches to management kind of highlights how much that we still need to learn about managing this very diverse and complex group of children and patients. I'll get started. We have a few more minutes before the next session starts. I just want to...
Yeah. Can I dive in then if you've got a few minutes? I was the surgeon involved and I still find it a really kind of extraordinary experience. I still feel slightly sick going through the medical history, but it is really interesting, and I'm still don't really claim to understand the physiology. I guess we assess the degree of ventricular dysfunction that she had. She'd obviously lived all of her life to 4 years with very high QP, QS and was quite volume loaded. But I think you could see this sort of as events materialize. It was interesting that we were worried, could there have been some coronary compressional problem that was the reason for ventricular dysfunction, but there never seemed to be. We saw normal flow in the coronaries on echo and on angio. Maybe the aortic regurgitation is an important component. But I still don't really understand why, when we reversed her systemic right ventricle no longer seemed able to cope, and she'd gone from having virtually no TR to severe TR. So it's a really interesting sort of story, but one that's still a bit perplexing. Her surgery itself seemed to go, reasonably straightforwardly without any sort of intraoperative concerns. Mike?
Obviously shared your emotions at the progress of this case, having been her cardiologist through this, and similarly, struggled to understand. I remember us talking on Monday morning, and you saying, I think we need to take it all down and do it again, put it back to where she was, and that did indeed get her off ECMO. So I think that was the right thing to do. We've subsequently had another case a little bit like this, similar physiology, late presenting patient with very high QPQS and big dilated ventricles, and we opted to put a band on pulmonary artery in this case in order to try and reduce the volume loading prior to double switch, with the idea that the ventricle can be not only sort of afterload dependent but preload dependent, and so if you're quite far to the right in the Starling curve, and then you close the VSD and reduce the preload of the ventricle, you may get an episode of poor ventricular function. And if that's bad enough that you can't actually sustain cardiac output, then that will result in the need for mechanical support. I'm still interested in the idea of whether we had left her for longer. The left ventricle could have recovered, and I guess we'll never know about that. But I think we proceeded to try and retrieve the situation, and of course we're all hoping that we will get a heart soon, that we could get a more stable situation for her.
No, thanks, Mike. I think I'd say it's still odd though to me, because I agree that maybe we still worry maybe we just sort of been waited longer on ECMO, but I guess if you don't get recovery, then you worry that the morbidities may accumulate. But I've done many double switches with VS in this sort of situation with volume loaded hearts, and never encountered this before. So I'd be very interested to hear if anyone else has any thoughts or experiences similar. Sorry, Anita, to bind in.
No, not at all. We really appreciate both Dr. Cdl and Dr. Barron's insights into this really complex case. I think we'll move on to the next presenter, and we'll save the additional questions towards the end in the discussion period. It's my pleasure to introduce Dr. Natasja de Groot. She is a professor in cardiology and electrophysiology at both the Erasmus Medical Center and in translational electrophysiology at the University of Technology in Delft. Her research focuses on unraveling the mechanism of cardiac arrhythmias, particularly arrhythmias in patients with congenital heart disease and pediatric patients in familial atrial fibrillation. She has developed unique signal recording and processing technologies to investigate cardiac arrhythmias. She's a fellow of the European Heart Rhythm Association and is involved in writing various international guidelines of the European Society of Cardiology, European Heart Rhythm Association, and Heart Rhythm Society. Dr. de Groot, we look forward to your talk this morning.
Thank you very much. Good morning, everyone. So the topic is the Icd therapy and cardiac resynchronization therapy in patients with congenital corrected transposition of the great arteries. This table nicely shows that there's a variety of arrhythmias in this patient group. And these tachyarrhythmias can be either supraventricular, ventricular tachyarrhythmias, sudden cardiac death, and also bradycardias. And if we take a look at the table, you can see that atrioventricular-oriented tachycardias are the main part of the supraventricular tachycardias, which is caused by the fact that 24% of the patients with transposition of the great arteries also have a W2W syndrome. And the other problems are the sudden cardiac death and the acquired atrioventricular conduction block. The interesting observation is that sudden cardiac death occurs regardless the presence of heart failure, and I can come back to that later. The first problem is, and that's also related to the ICD therapy, is the occurrence of atrial tachyarrhythmias, and that is in this patient group. It's quite frequently reported, and this table nicely summarizes the incidences of atrial tachyarrhythmias in patients with a variety of congenital heart disease. And we see here that the reported incidence of arrhythmias in congenitally corrected transposition of the great arteries is even over 30%. And another rising problem in this patient group is development of atrial fibrillation. And we see here, this was a study containing 199 patients with a variety of congenital heart defects, but also 4 patients with CCTGA. And we see that atrial fibrillation developed quite early in this patient group compared to other patients with congenital heart disease, but also compared to patients without congenital heart disease. And it's in 2 of them even before the age of 50 years old. Another thing is that what makes it even more complex in this patient group, that not only there is merely atrial fibrillation or atrial tachyarrhythmias, but sometimes a coexistence of these arrhythmias observed. So a patient has an episode of an atrial tachyarrhythmia, and without any intervention, this patient also develops either atrial fibrillation or vice versa. So it seems to be a complex substrate. And of course, the major problem in this patient group is sudden cardiac death. And the incidence of sudden cardiac death in patients with congenital heart disease, so it's more the entire patient groups, is less than 0.1% per year. And if we take a look at the 5 congenital defects with the greatest risk is the fallow, the transposition of the great arteries, but again, also the congenital corrected transposition of the great arteries. And this table summarizes the causes of sudden cardiac death in the patient with congenital, grow-up congenital heart disease. And you can see here that the sudden cardiac death reported incidences are quite variable. They range from like 50% to nearly 30%. And in the table below, you can see that the majority of the cases, so at least above 70% of the sudden cardiac death, is arrhythmic in cause. And of course, we want to identify the patients who are at risk of sudden cardiac death. And there we know the problems, and we know that that's also the way for patients without congenital heart disease. The risk factor, the common known risk factor is depressed cardiac function, your widening of the QRS complex, so that reflects an increase in your interventricular conduction delay to, for example, due to fibrotic areas, which play a role in the initiation and the perpetuation of ventricular tachyarrhythmias. And the presence of atrial tachyarrhythmias, it's generally assumed that atrial tachyarrhythmias cause ischemic, cause a myocardial ischemia, and in this way triggers ventricular arrhythmias. The presence of systemic atrioventricular valve regurgitation, aging, and that is now a problem because the surgical care and also the clinical care after cardiac surgery is improving. So this patient population is getting older, and that's becoming a problem for the development of arrhythmias. There are probably a lot of risk factors we don't know, and the one which bothers us as electrophysiologists the most is usually the presence of VTs, and of course mainly of non-sustained VTs. People come with a Holter recording, say, hey, this patient has non-sustained VTs. Is he now at risk for sudden cardiac death? And that's the main problem. I think we don't know. Because if we take a look at the sustained ventricular arrhythmias, we know that sustained ventricular tachyarrhythmias is actually quite rare, and the reported incidences are even below the 0.2% per year. But we also know that patients with congenital corrected transposition of the great arteries are actually a high risk group for developing sustained ventricular arrhythmias. But how do we treat them? We don't have that many treatment options. We know that antiarrhythmic drugs are often not effective. Catheter ablation is only considered as an adjunctive therapy. So we may usually end up with implanting an ICD. And this summarizes the ICD indications and for general patients with congenital heart disease. And of course, there's a class 1 indication when you have an out-of-hospital cardiac arrest or the patient has hemodynamically unstable FUT. So that also goes for this patient group. But when it becomes more complex, like you have risk factors, but not really an out-of-hospital cardiac arrest survivor, then it's more doubtful what to do, and particularly with this patient group. For a class 2B indication, we know that there is a high risk if you use systemic or right ventricular ejection fraction less than 35%, and there are also some adjunctive risk factors. It's also unexplained syncope, the NIA class. Again, the QRS complex, so widening of the QRS complex as an indicator of increasing conduction abnormalities, or patients waiting for heart transplantation. But still, there are no specific criteria for patients with CCTGA. And then we face the fact that if we want to implant an ICD in this patient group, you have some challenges because you are faced with patients who are actually quite young. And so they may already have a pacemaker and you have to upgrade them. So they may already have at least 2 leads in vivo, and then you have to add another shock lead to it. The patients are often young, and the leads have a high risk for failure, and you may require multiple replacement procedures of the battery. If you want to prepare the implantation, you're faced with a patient who often has no venous access. And if you implant a transvenous lead, we know that you have a high risk of venous occlusions, you might have embolic vascular event, and also endocarditis, which is, by the way, related to the replacement of the boxes. And if you have no venous access, you might consider an epicardial system. The advantage is that if the patient undergoes cardiac surgery, you might place it concurrently. You avoid the thromboembolic events. But on the other hand, there are also disadvantages for the epicardial systems. And that is that you have a higher failure rate, but also we know that the higher failure rate is associated with the fact that you have an increase in your pacing thresholds when you have an epicardial lead. And what about the follow-up afterwards? Well, there are a few reports and based reporting on the follow-up after an ICD implantation. And you can see here, there's a table which summarizes these studies. The follow-up is not that long. It ranges between 2 and almost 5 years. And I think the interesting thing is that there's one study, by the way, from Paul Carey, who is actually dedicated to the patients with the transposition of the great arteries, but in all other cases, and they are quite mixed. We see that the percentage of appropriate shocks is 23%, but even worse, the percentage of inappropriate shocks is nearly 25%. And that is mainly caused by the fact that these patients have an inappropriate shock as a result of the development of a supraventricular tachyarrhythmia, and then in particular atrial fibrillation. And then we have the cardiac resynchronization therapy in this patient group. Is it a beneficial therapy? And that's really something we can argue on, because if the indication for cardiac resynchronization therapy in patients without congenital heart disease is quite clear. We know you need to have left ventricular dysfunction, you have interventricular conduction delay and interventricular conduction delay, you have an impaired cardiac output, and if you place an additional lead on the ICD, and for cardiac resynchronization, you have a clear indication. If you have a left bundle branch block, you have a left ventricular ejection fraction less than 35%, and you have a QRS complex, which is broader than 150 milliseconds, it's clear. And then it's a class 1 indication. And you could also translate this to the congenital heart disease, and that is what actually has been done. It's less doubtful when the QRS complex is somewhat smaller, then it becomes a 2A, and it's even more difficult when you have a left bundle branch block, and also when you have a QRS complex which is smaller, so then it becomes a 2A or a 2B. But that's just for the patients without congenital heart disease. And we know that we need to make a decision on this, because if we take a look at this graph, I think it's very nicely here, you see that at the age of 55 years, 76% of the patients with CCTGA who have associated lesions will develop heart failure, versus even 25 in those patients without associated lesions. So we need to improve there. And we know some risk factors, which are summarized on this slide, but it still remains very difficult what the exact indication of CRT therapy is in this patient group. And these studies were actually the first who published on cardiac resynchronization therapy in patients with CCTGA. And here are the numbers. They're actually quite nice, ranging from 48 to even 109 patients. And this is the first publication. This was from Jan Jausik, already published in 2004, and he implanted CRT devices in this patient group. And you can also see at the QRS delay that those patients, except for one, had indeed prolongation of the QRS complex. And he also analyzed whether there were acute positive hemodynamic effects of CRT, and this is what you can see in this slide. And he indeed demonstrated that there was a positive impact of the CRT device on the cardiac hemodynamics. He also analyzed that for the midterm changes and could show some beneficial impact, but still the numbers are small. And then if it comes to pediatric patients, Anna Debin was the first to demonstrate that it was also effective in a few patients, and actually they were also removed from the transplantation list. Thus there is some evidence. And also she demonstrated that there was an increase in the ejection fraction in the pediatric patients who received a CRT device. And then the evidence increased, and people were demonstrating either you have an improved ejection fraction or you improve in New York Heart Class Association. But it all remains with reporting cases like you see on this slide. And then it comes to the technical aspects that was reported by Jauvert, who actually demonstrated that it's also technical feasible. I've shown you that there are some challenges. And in some patients, when you don't have venous access or you have limited venous access, you can also use combined systems. And that's what he actually demonstrated. And here it was nicely shown in only a few patients with CCTGA that cardiac resynchronization therapy actually also improved the ejection fraction of the systemic ventricle post-CRT, so during a follow-up of 3 months, and this was actually first with somewhat a longer follow-up. But then in 2007, this paper was published, which actually showed that in nearly 10 patients with CCTGA was quite a mix of response. And actually that the majority of these patients did not respond well. So there was no improvement in ejection fraction and also not in the functional class. So if we summarize these studies, we know that there are a large number of studies. They report both on short and long-term outcome, but they are actually lacking. If you take a look at the study population, you can see that both it's a mix of underlying defects, but it's also a mix of pediatric and adult patients. Patient-specific data is often not described. So you have a study population that report that the patients have CCTGA, but you cannot retrieve the data in the outcome which patients were actually improved. And so far the follow-up was limited to only 6 months. Another thing is that there was no uniform selection criteria, and we all know that feeling that if you have the question for yourself, like does the patient need a CRT, that's a little bit vague on which criteria you actually decided. And also there were no predefined measures to examine how efficacy is actually the CRT. What is the most optimal parameter in this patient? Because we actually just use the parameters from patients without congenital heart disease. So we reviewed this and we came to the conclusion that there were actually no guidelines on it. So within the group of PACES, we decided to investigate the short and long-term outcome of CRT in this specific patient group. So these were all the participants in the study, and we included mainly so patients with CCTGA, but also patients with DTGA. And here you can see the variables we collected. So yeah, we had no, of course, we could not come up with new parameters. You always have to do it with retrospective data. So we still used all the parameters which were collected in all other studies. So we analyzed the indications, what type of device was placed, where was the lead displaced, what kind of complications were developed during the procedure. And we also tried to identify the pre-CRT outcome and both during long-term and short-term. So we included in total of 80 patients, and the majority of them at CCTGA, like almost 80%. The median follow-up time is 4 years, so it's still not long, but it's longer than so far published. And you can see in the table below, there was actually quite a mix of indication, and sometimes it's what the indication was actually not known. The lead implantations is shown here. The majority of the patients received a transvenous lead, and only a minority had the epicardial approach. Also, the position of the lead, which might actually be a very strong parameter of the outcome. It was quite a mixed bag, as you can see here. The majority of the patients had the lead positioned in the mid segments. And when we analyzed the outcomes, we had actually two patient groups, those who had a pacing device prior to implantation and those who did not. And we can see that in the short outcomes, we see a prolongation of the QRS duration. That's quite interesting in the patients who had no CRT device. There was an improvement in the NIA class, but no improvement in the ejection fraction. And in the patients who actually had a ventricular pacing, you could see that there was a decrease in the QRS duration, an improvement in the NIA class, but no improvement in the ejection fraction. And if we go to the long-term outcome, so that was an average of about 4 years, we see again that in the patients without pre-CRT, there was an increase in QRS duration, and not really an improvement in NIA class, and also no improvement in the ejection fraction. And in the patient with pre-CRT, there was a reduction in QRS duration, an improvement in the NIA class, and a marginal increase. It's not really impressive. The statistic says 0.04, but if you take a look at the numbers, you can actually say that it's really not affected by it. So that was quite surprising. We also did not find a difference between the transposition of the great arteries, so the CC of the DGA. And also it did not matter whether he had a transvenous system of an epicardial or a mixed system. So from the data so far, we can conclude that cardiac resynchronization therapy, particularly in patients with SSN dysfunction and pacing-induced dyssynchrony, had some consistent improvement in the QRS duration. So the improving that there's conduction improvement in the ventricles and the functional status, but there was not clear an increase in ejection fraction. The observed beneficial effects, they occurred particularly in the patients who already had a pacing device. The reasons below, the reason underlying this observation is not very clear, and I think that the numbers need to be larger for that, and also the parameters need to be defined. So if we take a look at the problems we have to solve in this patient group, is if we provide them with a lead, either pacing or an Icd lead, what is the most optimal pacing position, and what are appropriate long outcome measures specifically for this patient group, because we use them from all other patient groups. How can we actually accurately identify responders? I don't think an echocardiography parameter just estimating an ejection fraction is not good enough. And I also think because we all have a few patients, larger prospective multicenties are actually needed to answer those questions. Just within the time, so thank you for your attention.
Thank you so much, Natasha. I think you were given the impossible task of reviewing arrhythmias, pacing, CRT, and ICD in such a short time, and you did so with a beautiful review of the literature, so thank you. I know we're running a little bit behind, but I do have one quick question that I'd like to ask you. What are your thoughts about physiological pacing in this patient population? In other words, his bundle or left bundle branch pacing?
Yeah, I think that's the new thing, the most exciting thing, which it might be, I think that it's beneficial, will be beneficial in this patient group. I know that already some hospitals in the United States are starting with it. And it makes sense just to follow the normal conduction system, because whatever you position the lead, the tissue of this patient is highly anisotropic in nature. So if you place a lead somewhere, we have observed that you are, when we do high resolution mapping and during pacing, we actually see that there are lines of conduction block developing at the site where we would normally put a CRT lead. So I think that's really a challenging and a very exciting option, which is promising for this patient group.
Agreed, yes. And you highlighted in your talk a really important point in that, there are no clear indications for CRT implantation in this group of patients. And oftentimes we kind of extrapolate the adult CRT guidelines that are really based on ischemic cardiomyopathy, right? Yeah. And so, for example, one factor that we look into is electrical dyssynchrony as well as mechanical dyssynchrony. But as you yourself pointed out in this multi-center study that you just did, that you don't necessarily see a reduction in Q restoration. So I'm curious and would love to hear your approach and your institution's approach in evaluating CRT candidates.
The selection of the candidates is usually performed by our congenital heart disease doctor, so to speak. But there it still remains like, usually the argument, what I hear often is like, hey, we have nothing else to offer. You've tried your drugs. It's optimal medical therapy. Is this something you can try? Because this patient has such a poor functional status. When you have, of course, when you have non-sustained fatigue, you have an additional argument because you're thinking about an ICD. So why not putting a third lead in? All these kinds of little arguments. But heart criteria, we are clearly lacking, and we also don't have, unfortunately, in our hospital.
Right. No, I agree. I think what we do know is univentricular pacing, either the morphologic RV or the morphologic LV, either in physiologically or anatomically corrected CCTGA patients, is bad. And so we know that primary biventricular pacing, not necessarily CRT, but biventricular pacing is ideal even from the get-go in the absence of any electrical dyssynchrony or widened QRS for their age. And so I wonder if biventricular pacing is not necessarily treating electrical dyssynchrony, or if it's just changing the mechanics of the septal motion and, perhaps preventing or improving, systemic AV valve regurgitation and preserving function over time. I think that's an interesting thought to explore.
Yeah.
Thank you for your great talk.
Great. Thank you for that excellent talk, Dr. de Groot. Hello from Toronto, and I have the pleasure of introducing our next speaker. Dr. Lucy Roche is a pediatric and adult congenital cardiologist who founded Toronto's ACHD Heart Failure Clinic in 2012. Her clinical and research interests lie in aspects of complex congenital heart disease that affect patients across the age spectrum, one of the most pressing of which is heart failure. And we will hear, I think, a lot of interesting things from Dr. Roche in her talk right now. So welcome, and thank you for making the time for us.
Hi, thank you very much. I've pressed the wrong button and skipped on. But anyway, thank you very much for the introduction and for letting me talk today. I'm very interested to hear all the other speakers in this session as well. I'm going to speak about transplant and VAD in CCTGA. And it's quite a big topic again. So I'm going to just try and focus on these 4 areas. Hopefully I can see my screen okay. So I'm going to talk about the challenges of advanced heart failure therapies in CCTGA and why it's so difficult in this subgroup of patients. I'm going to talk about the timing of assessment. I've seen some questions in the chat about that. When should we start thinking about these advanced heart failure therapies? What would be the signals to do so? And what are the outcomes of transplant and VAD in this population? And what do we know about that at the moment? And then finally, I'm going to just try and talk about some ideas for how we might optimize some of those outcomes given what we know so far. So let's just start with the challenges of advanced heart failure therapies. Well, I think really this whole conference has outlined them very well, and I'm sure you've heard this in lots of different ways, but the real challenge is that there are so few patients with CCTGA, and within that rare lesion, there is such a broad spectrum of disease, anatomy, physiology, and even within that, we then do different types of repairs on these patients. So by the time these patients start to have heart failure, we're left with very few patients in each of these groups, and it's quite difficult. Each one of these groups poses different problems to the idea of considering VAD or transplant. So for instance, whether or not a person has severe tricuspid regurgitation or an intracardiac shunt, if they have a subaortic right ventricle versus a subaortic left ventricle with outflow tract obstruction, and finally a Fontan circulation. And I'm not really going to be able to delve into all these subtleties today, but I'm going to just try and talk about some to pique your interest. So this is a paper looking at Texas children's outcomes for all types of mechanical support in children. And they include this nice slide, which illustrates, I should have given a warning that it's an operative slide, sorry. The outcome, like a situation with a patient who was 8 years old, who'd had an anatomical repair of CCTGA, a part of which included a double switch. And they were trying to put the patient on a VAD. And you can see, so the head of the patient is at the top of your screen, the feet are at the bottom, the right is on the right-hand side. And the problems that the surgeon faced was that lots of stenotomies, so getting in the chest was difficult, but also the RPA, because of the way the arterial switch had been done, was now directly over the ascending aorta, which is exactly where you might put the cannula for your VAD. So they had to use the graft to back up to the innominate vein and find an alternative way to empty the VAD back into the systemic circulation. So that's a challenge from an anatomical repair. For physiological repairs, there are lots of things that make the situation for either transplant or VAD more complex. So some of these patients have dextrocardia, some have isomerism with abnormal venous anatomies, and you have to then try and fit a heart from a donor who doesn't have those things into that situation, or reconfigure your VAD so it's going to fit. If a patient has LV to PA conduit stenosis, you might need to deal with that before you suddenly put a full cardiac output back into that subpulmonary LV and expect the conduit to cope with that. Our patients have had previous surgeries, and that can make them sensitized, in particular if they've had a conduit that's a homograph. That makes the wait time much longer if they're highly sensitized, so that's something to bear in mind. We just heard there's a lot of patients who end up with complex pacemaker strategies or CRTD and wires and patches and all sorts of things that can make reoperating on the chest more difficult. All of these diagnoses, if they've had surgery in the past, if they've had any valve surgery or conduits, are more at risk of endocarditis, and sometimes we find ourselves facing these difficult decisions in a patient who's quite sick with endocarditis. Pulmonary hypertension, I'm going to talk about a little bit more, but that's a uniquely prevalent situation in these patients that does really impact the options that we have available for them. When we think about putting in a subaortic right ventricular assist device, we also have to think about the left ventricular function and whether that's going to cope, and I'll talk a little bit about that. And then any residual ASDs or VSDs will affect, if you're putting in a VAD, it's going to affect the shunting. As your subaortic RVAD sucks, you'll make the patient desaturated, so you have to identify all these things. So this is a very complex situation, different for each patient, and every single patient, before you think about your options, you need a very thorough assessment of all of these parts of the puzzle. I include this because it's one of the first papers, the actual first subaortic RVAD was put in 2009, I think, or the first published papers. But this paper from 2010 was a good one because it explained some of the anatomical complexities of doing that. They use a DeBakey VAD here, and they really point out the fact that if you put an apical cannula, you're going to end up with this moderator band and the trabeculations of the right ventricle kind of potentially obstructing your inflow. And this was the first paper to talk about that, and several other papers have explained surgical techniques for managing that. On the right is a chest x-ray from one of our CCTGA patients with a VAD, and you can see that the VAD position is quite different to the normal position of VAD in a patient with a normal anatomy heart. And then when you think about, I put this slide in to remind me to say that there are all these anatomical and physiological complexities, but all of those are within a patient. And we really need to think about the person who's around the heart, because that really impacts the decision-making process and how we work with that patient to come to the right decision for them. So you may have seen this diagram, which talks about the neurodevelopmental and psychosocial milieu and all the things that happen to that person from fetal to adult life, so through childhood, that can affect the way that their brains function, that they are able to handle different situations, the way their social support network is available, like how many has their family stayed together during that time? All these things make a really big difference to the way the person views themselves, their life, and their options as they age. And most of this transplant and VAD discussion, if it's not in the perioperative surgical time, as the case we discussed earlier, will be in older adults. So all these things play a role and are really important to consider. And so that's why I put this slide in. So then the timing of assessment is obviously something that we all wonder about and we're all uncertain of. And even beyond that, we're not quite sure who should be assessing these patients. But I want to bring this into play. This is a picture I think you'll recognize, hopefully, of the Titanic and the deck chairs on the Titanic. And it's to remind me to say that, to be honest, very often once patients with CCTGA have heart failure, advanced heart failure therapies are probably the only effective therapies. We've heard a lot about the lack of evidence for medication and even pacing actually changing the situation for these patients and the change in life expectancy. But many times we spend a lot of our time trying to use those simpler techniques really to help patients, and perhaps what they really need is to be in a situation where they can have the advanced imaging and hemodynamic assessment needed, where they can see an advanced EP doctor and consider all of these options for VAD, transplant, high risk tricuspid valve surgery, other options that might be possible percutaneously. And that really takes a specialized team who are used to having these conversations. And you'll see a lot of patients, particularly in adult life, might not be followed by an ACHD cardiologist. And so one of the problems is that we need to get those patients back into this care pathway as soon as possible. And then I would echo what Raphael said, our transplant and heart failure team is very happy to speak to patients quite early on. Even if we don't continue following them, at least we can set the stage with them and start engaging them in the decision and helping them to understand the situation they're in. But when you think about actually listing a patient for transplant or putting a VAD in, these are the rules of thumb. I think I've made them up. I can't remember if someone taught me them along the way, but I'm not sure. But I kind of think if people's life expectancy is less than 2 years, and that takes into account the time for assessment and listing and waiting on a transplant list, that seems a reasonable aim to me. If their quality of life is intolerable, and we'll come back to what that might mean, and it's very difficult for us to say that about our patients, but it's something to consider. And then if there are comorbidities which are either progressive such that they'll eventually preclude heart-only transplant and limit the options of that patient, or if these comorbidities will prolong wait time, you might want to refer a patient earlier for consideration of transplant and VAD. So a few things on life expectancy. The literature really is in two phases. So there's this literature about ACHD heart failure in general, and then there are specific literature to the 2V RV circulation, so biventricular circulations with a subaortic right ventricle. There's very little about CCTGA specifically. So just looking at them together, I would always be very alert to a patient who's had an admission with heart failure. The data suggests that that patient has a 5 times higher chance of dying than in the next few years than a patient who's never been admitted with heart failure who has congenital heart disease. We recently looked at some Ontario data comparing the chances of dying after a first heart failure admission if you have ACHD and if you don't. And it's much higher for patients with ACHD than non-congenital patients. And some people think it's up to 25% in the first year after a heart failure admission, patients might die. So to me, that would be a clear trigger to at least have these patients referred to discuss their options. And again, the atrial arrhythmias can be a very strong signal of heart failure. Sometimes these things are very woven and interlinked and it's hard to separate them. But patients who have atrial arrhythmias have a more than double chance of dying in the next 5 to 10 years compared to patients who do not if they have congenital heart disease. So that could be another trigger, particularly if they're having recurrent episodes of atrial arrhythmia. And then the literature specific to subaortic right ventricular circulations, well, there's not much about ventricular function. You've heard several times today how if we just use ejection fraction, it's very difficult to be a precise measure of how poorly somebody's doing. If you have very poor subaortic right ventricular function, you do less well than someone with normal right ventricular function. But within that group of very poor, which is almost everybody when they become an adult, it's very hard to pick out which ones have a less than 2-year life expectancy. So we did a study looking at our 2V RV patients in the congenital heart disease clinic, and the things that we found that were helpful with that limited number of patients that seemed useful to us were to look for pulmonary hypertension and look for patients who have elevated BNP. And I'm just going to show you a few slides from that. Alexander van der Braun, who was with us as a heart failure trainee for a couple of years, did some excellent work with us and looked at all our patients who were over 18 years in the heart function clinic who'd had a biventricular subaortic right ventricle circulation, who'd had a cath between 2000 and 2018. And he looked at the echo measurements, he looked at the biochemical markers that we'd recorded and the exercise capacity. And he graded people on the invasive cath data as to whether or not they had pulmonary hypertension as per the ESC guidelines, and looked at a composite outcome of time to death, transplant, or VAD. He found of the 141 patients in this situation who'd actually had a cath, and this is the largest number reported at that time with invasive hemodynamic studies, 55% had pulmonary hypertension at baseline. And it was interesting that we could not predict that from the echo. So the mitral valve regurgitant velocity and LVSP were very poor predictors of pH, and similarly of absence of pulmonary hypertension. And the pH prevalence was similar whether the patient was a mustard setting patient or CCTGA. You can see that it's about 50% for 64% for the CCTGA patients. And actually isolated precapillary pulmonary hypertension was rare. Most people had mixed or post-capillary hypertension, presumably secondary to that failing RV and the elevated LA pressures. So it's just very interesting to us to see that this was a very prevalent finding in our patients, and it hadn't been reported previously that CCTGA patients, as well as it's been long known for transposition, that patients are at risk of pulmonary hypertension at whatever way you manage their transposition, but it hadn't been previously reported for CCTGA. And we found that if you looked at, this is a whole group now, not just CCTGA, combining the patients who had a BNP of more than 100 and patients who had pulmonary hypertension, it was a quite strong predictor of adverse outcome over the short duration of follow-up. The median duration in this study was actually 2 years. So all of these patients who had outcomes had them within 2.5 years. Whereas if there was absence of the pH and normal BNP, they actually did quite well in the short term. So I find that this is something I use all the time in clinic. When I see a patient with CCTGA, I always check the BNP, and if it's elevated, I will often get a catheter to measure the pulmonary artery pressures, just to have in mind whereabouts the patient might be, because as you all know, that if the pulmonary hypertension is too high, and they will become a candidate for heart-lung transplant rather than heart transplant, and that has a very different trajectory in the long term for that patient, very different outcome. So just to go over those again, life expectancy less than 2 years, intolerable quality of life, and then these comorbidities. So the comorbidities that I would think about are the pulmonary hypertension. I've told you, we also saw that it progressed quite quickly, and it was difficult to follow on echo that it had progressed. So those patients should be considered for advanced therapies. Obesity, smoking, and drugs. If you have patients who are quite well, you might want to talk to them about these things, because these will preclude or make transplant more difficult. And it's best to talk to people at a long time away from actually needing a transplant or a VAD, to see if you can help them alter these habits when they really understand their life trajectory. Diabetes can also affect outcomes. So in those patients, you really don't want to leave it till the last minute to start thinking about transplant and VAD. Previous pregnancy, you might think is a weird comorbidity, and Candice would probably disagree with me for calling it a comorbidity. But HLA sensitization, the two things that sensitize patients are in these groups of patients are homographs and pregnancies. And so when a patient has a pregnancy, it's very likely they will develop HLA antibodies. The level, and we can't tell you how much, but those patients are more difficult to transplant if they've had multiple pregnancies, even if those pregnancies weren't completed. So those patients who've had lots of previous pregnancies, you might refer earlier. And loss to follow-up is a real marker of doing poorly in the long run. So this study is a study by Philip Moons from Belgium, and he did a meta-analysis of loss to follow-up patients, and found that it's very variable from where you live, but up to 25% of ACHD patients will be lost to follow-up after the time of transition. So those patients who come to emergency rooms or other types of doctors and have an interaction with an arrhythmia really need to be fed back into a system at that point, because those are the ones that are going to be at higher risk in the long run. So what are the outcomes of transplant and VAD in these patients? Just keeping an eye on the time. There is little data specific to CCTGA, so I'm going to show you what I can. There's an INTERMACS registry. INTERMACS is a a US registry of everybody that has mechanical support, inter-agency registry. And they recently did an analysis, or not recently, but a while ago, did an analysis of everybody who's had mechanical support in ACHD. And they found 126 patients who were congenital compared to 16,000 or more who were non-congenital. And you can see that within that, in the whole of the US, there were 45 patients who'd had mechanical support for a subaortic right ventricle. So the numbers are small, and you can see in this picture, many of them were all from 2 hospitals. So it's not widely available. So when we talk about these things, to be honest, not every patient is able to get access to these treatments. And so obviously, if you've only got 45 patients spread throughout the US, the data, and we don't know here how many have CCTGA, the data about outcomes is limited somewhat. But what they found was that the outcomes for adult congenital heart disease patients who were supported with a systemic ventricular assist device were really the same as for the non-ACHD patients. And that's the same applies in the second half if you were a morphological right ventricle versus either a non-ACHD person. They say LVAD, it's what I would use as systemic subaortic right RVAD, but that's what they mean. But there's no difference in survival, saying that really, this is a good strategy for patients. At least it's definitely no worse than it is for non-congenital patients, and yet congenital patients get very limited access to it. There are some single center experiences. This is from Belgium. It's recently published. You can see this year. It's a single center experience of 5 patients. We have also done 5 patients in Toronto with a subaortic right ventricle, 5 adult patients. But only 2 of them had CCTGA. So the mean age here was 30, median age was 38. Pre-VAD, all of them had post-capillary pulmonary hypertension, and 4 out of 5 had a PVR that was elevated to the point that you would not be able to do a heart-only transplant. In this series, there was no VAD implant mortality, but you can see that the patients tend to stay on ICU quite a long time, so up to 7 days on ICU, and maybe the average discharge was 19 days, but somebody stayed 105 days in hospital. They're complicated operations. All of the patients experienced a post-implant drop in their pulmonary artery pressures and hemodynamics, and all 5 were ultimately able to undergo a heart transplant in this study. Some of them waited up to 200 to 300 days from VAD to transplant. Something wrong with that scale there, sorry. This is the largest single center experience, also published this year from the Freeman Hospital in Newcastle, 18 patients undergoing subaortic right VAD. Here again, only 2 of those were CCTGA patients. So if I add it up in my head, I think there's probably 10 CCTGA patients in the whole world at the most that's ever had a VAD. So it's a big talk in this conference for a small number of patients. These patients all often had moderate subaortic LV impairment, subpulmonary LV impairment, worth noting that. Nevertheless, most of them still had just a single subaortic VAD rather than a BiVAD, and 13 had a transpulmonary gradient that precluded heart-only transplant. In this 18 patients, only 1 were they unable to establish on durable VAD support, and that patient had had 4 previous stenotomies, and they found it was impossible to really establish good cardiac output, and he died post-operatively on ECMO a few days later. 2 patients had an aortic valve replacement during their VAD surgery, and 6 had a tricuspid valve replacement, and I'm going to talk about that again. So some of these patients need more surgery. In our practice, the only 2 CCTGA patients that we looked after, one of them needed the LV to PA conduit replaced. That was a huge operation, and the patient, it was our first VAD in a CCTGA patient. Sadly, the patient died of a neurological injury. The surgery went okay. We managed to establish support, but about a week later, it was very evident he'd had a severe neurological injury, so he died, unfortunately. In this study, 12-month survival was 72%, and a third of them, remember, most of them were heart transplant ineligible, but a third of them received transplant. So that's the survival curve. You can see that there were quite a lot of complications for these patients to go through. This is the patients individually, and I just linked here in highlighted that you can see the 2 with CTGA, 1 who is transplanted and alive, and 1 who died on support about 10 months after a VAD. That patient was 60 years old when the VAD was implanted, the one that died. The only other data really that we have is this STS, so the Congenital Cardiac Surgeons of North America database, looking at all the operations that have been done in CCTGA, you'll see, if you look carefully, that there's a column for heart transplant, and there are 61. I've just highlighted that here. So most of the heart transplants in CCTGA are done in children. I don't think that's because most of the patients that could benefit from one of them are children. I think it's because all those children are followed by pediatric cardiologists and have more access to it, rather than the people who are over 18. But there are 39 who have been done in patients who are over 18. But you can see the numbers per year are very, very small of heart transplants in this population. So when we think about outcomes, we need to think about how we're thinking about outcomes. There are people who may benefit from advanced heart therapies, are quite a lot of the population perhaps of CCTGA, but not all of those are followed by a congenital cardiologist, and not all of those have a cardiologist who's going to refer them for transplant assessment. And then there are the people who may benefit and are referred and are accepted. And there are people who benefit who are referred and accepted and undergo a VAD. And it's really only this bottom blue column that I've talked about the results from. We don't know what happens to all the rest of the people. And that's important. There was a study, again, from Newcastle that tried to look at outcomes after referral. So of 196 adult patients referred for transplant, there were 57 who were a biventricular circulation with a subaortic right ventricle, and 23 who were CCTGA. And you can see that actually the subaortic right ventricle group do the best after referral from transplant. This is whatever decisions made. This is just, are they alive 15 years after transplant or not, after referral? And this is how the outcomes go. And you can see that there is, in a competing hazard analysis, about 10% of patients die once they're on the transplant list. So that's another thing to think about. And maybe that's because we can't support the patients as much as we like with VAD. But of those that get transplant, those patients who have a subaortic right ventricle actually do very well in this study. And we would expect now that many patients with congenital heart disease do very well after transplant. The outcomes are quite similar in some centers to non-congenital heart disease patients, depending on, there's lots of factors around that. If you look at single center data, it definitely can be very similar. But it's interesting to see here that in this group's hands, the subaortic right ventricular group do well. And that's really encouraging in terms of referring patient. So just finally, I hope I have a few minutes left. I've lost track of time. How do we optimize our outcomes? Well, first of all, we need to flatten that learning curve, because hardly any patients get referred. So experience is few and far between. So we need to maximize the experience we have and learn from other groups. One way of maximizing experience is obviously to put all the patients in single centers, like so that you refer to an expert center with expert team around them to try and consolidate that experience, both from the assessment process and the experience of the surgeons and the management afterwards. Learning from other groups is really important. We can learn it by looking at data, as we've done today, and there are databases and single center analysis, but really it's very helpful to do site visits, to meet with our colleagues, and sometimes to discuss our patients on, now that we have Zoom, we can discuss patients in multi-center, multidisciplinary team meetings. And I really think we need to develop care systems across the country for these patients. So this is an example of how we're trying to consolidate our experience. This is a paper that we wrote with colleagues from Toronto, from the Freeman Hospital, from Leuven, and from Texas Children's Hospital, which is very technical on how in our experience, it's not scientific, it's a this is how we did it kind of paper with the patients that we've looked after, where we have implanted a subaortic RVAD. And then if you're interested, I put the reference here. The group from the Freeman, in their 18 patients, actually suggest that one way of improving outcomes is perhaps to replace the tricuspid valve in all patients with a tissue valve. They found that improved subpulmonary left ventricular function in the long run, and they think their premise is that might allow people to live longer with their VADs until they get a transplant, and it might reduce the pulmonary artery pressures better so that they can get a heart-only transplant. Quite a lot of detail in this paper. It's worth a look. And this is my idea for systems. I think we need the patient, if you imagine a pyramid, needs to be supported by an ACHD heart failure program who are supported by a team of ACHD cardiologists, all feeding into each other, and also supported by a heart transplant and VAD team and cardiac surgery and anesthesia. And all of that needs to be within a division of cardiology. Everybody needs to buy into this. It's a very labor-intensive, difficult, high-risk strategy. Patients die here, and when we do these things, and it can jeopardize transplant teams and VAD programs. So everybody needs to buy in to support these patients at the top, including the hospital. And I think nationally, we need centers of excellence that patients get referred into so that we can do that consolidating experience. Oh, Sorry. So the only thing, I keep coming back to this spectrum because there's a spectrum of CCTGA, and I want to remember that the spectrum of people that we see, the visible spectrum, does not reflect the patients who are lost to follow-up or who are out there. And really one of the probably the best things we can do to improve outcomes is ensure people don't get lost to follow-up and find the patients who are. So my take-home messages would be that I think VAD and transplant are probably as good an option for CCTGA as they are for people without congenital heart disease. And if we refer patients to specialist heart failure teams, we're going to be able to evaluate the options in partnership with the patient, provide high-risk surgical interventions, maybe not VAD and transplant, but maybe VAD and transplant, as well as these advanced heart failure therapies. And it's really important on top of all of this to provide appropriate support for the patients. Thank you very much for your time.
That was a fantastic talk, Lucy. Really appreciate it. I have many questions to ask you, but I think in the kind of taking into account the time at the moment, maybe we'll move on to the next speaker and then kind of tackle some questions in the chat or once we have time permitting at the end.
Perfect. Lucy, Dr. DeGroot, thank you so much for such captivating talks. I'm really fascinated with the discussion to come in a bit. But I'd like to introduce Marcus Schwarzman to round out the session today. Dr. Schwarzman is a clinician scientist at the University Hospital in Cellspital in Bern, Switzerland. He trained in internal medicine and cardiology in Switzerland prior to coming to Toronto for his adult congenital heart disease fellowship. He's currently the acting director in the adult congenital heart disease unit at the Center for Congenital Heart Disease in Bern. And his research interest focuses on clinical outcomes in adult congenital heart disease, particularly those with a failing right ventricle. He's the principal investigator of an international placebo-controlled randomized clinical control trial aiming to improve the fate of patients with systemic right ventricles. And he has a particular interest in the area of transitioning process, as well as the perspectives of approaching end-of-life care. I'd like to welcome Dr. Schwarzman to give us a talk on advanced care directives in CCTGA.
So thank you very much for this nice introduction, and thank you very much for allowing me to address a rather soft topic, but nevertheless very important topic for our patients. It's about advanced care directives in adults with congenital heart disease. We have heard now two rather technical, fantastic talks about the opportunities medicine can offer to these patients, but I think it's equally important that we talk to patients and we try to assess what they really want. And this is actually the aim of advanced care planning. Advanced care planning is actually a process that supports and empowers individuals at any stage of their life or the disease to communicate, document preferences for future healthcare to the loved ones and to us healthcare providers. So we ideally talk to patients at a time when they are still doing well and try to assess what are their goals, their wishes for the moments when their health will decline. And advanced care planning usually ends with a couple of products like advanced directives, physician orders for life-sustaining treatment, and the naming of a healthcare representative. Just for the wording, advanced directives are a more broader set of preferences and decisions for medical treatments patients define in advance of a potential serious medical situation. And as you know, POLS documents are more the documents the doctor needs in case of an emergency, in case of cardiac resuscitation, to do exactly what patients want them to do. There are many studies there outlining the benefits of advanced care planning in cardiovascular diseases. Most of these studies deal with heart failure or advanced valvular heart disease. And benefits of advanced care planning can be found on an individual level, on a family level, but also on a healthcare level. And for the individual, they are more likely to have the opportunity to die in the preferred place. And this is not necessarily the ICU. These patients have more often a sense of relief and control because they can decide also in the end what happens to them. And usually they also spend less time in hospital because these patients usually don't die or are less likely to die in the ICU. For the family, the benefits of advanced care planning is that they have an increased awareness of the patient really wants, and this often leads to a more congruence regarding care objectives within the family, and this may be particularly beneficial for the healthcare provider because it doesn't have to deal with diverting opinions. And on a healthcare level, there's a reduced length of stay in the hospital. This leads to reduced costs and also usually to improve this provider satisfaction. So there are many benefits of ACP that have been proven for heart failure, valvular heart disease, which apply most likely also to ACHD patients. The problem with advanced care planning that it's a question of timing. We don't want to address this issue too early, but also not too late. And the problem with timing is that the right timing is usually not the doctor's timing. And just have to laugh a little bit. When you look at today's program, you can see we talk about pacing, we talk about assist devices, transplant, but we talk about advanced care directives only in the end. And just from a timeline perspective, my talk should have been the first one. But I think this expresses a little bit the way that we as doctors approach advanced care planning. And this is really a very interesting study from my colleagues, Daniel Tobler and Matthias Kreutmann, also during the time they spent in Toronto. And it shows how talks about end of life are perceived by patients and by doctors. And if you ask patients about what they recall about talks about end of life planning, then only 1% or 2 of 200 recall such talks. But 80% actually want to have these kind of talks, and they usually wait for the medical team to raise these issues. They don't raise usually these issues by themselves. And most patients want this talk independent of disease complexities. And such as the full-time patient or the CCTGA patient wants this talk, it's also the coarctation patient or just the patient with a closed ASD. And 2 or 3 patients are in favor of early initiation. This means before they are at the ICU, before they face life-threatening complications. If you look at the doctor's perspective, half of the cardiologists say, well, we typically discuss life expectancy, but interestingly, only 1% of patients recalls it. And doctors usually reserve this kind of talk to complex lesions, and only 1 in 3 of the doctors is in favor of early initiation. And as I said, the issue is that it's a question of timing. We shouldn't address advanced care planning at the point in time when the patient's health is clearly declining, but also not when it's much too early. And the problem is that we don't have this kind of crystal ball who tells us when a patient is going down the hill. So because we don't have this kind of crystal ball, we have to, let's say, define the disease trajectory with the means that we have. And well, we know just based from the literature, based from all the talks we heard so far, that actually most or nearly all of CCTGA patients will have health issues, be it heart failure, arrhythmias, or heart block at one point in time, and most often during the 4th or 5th decade. Of course, you can find case reports of women 82 years of age who are incidentally detected to have CCTGA, but this is really the exception. So we know that most patients will face problems once they are in their 40s or 50s. So to refine the crystal ball, to find our timing for advanced care planning, I think we have different components we can look at. We can look at patient's event, clinical event, interventions, just at the epidemiology, test results, and what I call soft factors. And Patient's events are, for example, if a patient just has lost a peer with another form of ACHD, and he thinks about his own future. Or clinical events are, as you have seen, if a patient has a first episode of decompensated heart failure. Interventions are the patients who needs a new AV valve, the patients who needs ICD, or of course the patient who we discuss for assist device implantation. And then epidemiology. I think if a patient CCTGA has approached 50 years of age, I think independent on how he's doing, it's just time to remind him that maybe in the future his health might decline and offer him the opportunity to talk about advanced care planning. Then we have test results. We have seen that neurohormones can predict outcome. We have also exercise testing. If you see that this exercise capacity is declining, then we may know that the patient is doing less well. And I think one personally for me important factor or red flag is the so-called surprise question. If I'm sitting in front of a patient and I wouldn't be surprised if he would die within the next year of life, and I haven't addressed the issue of ACP, then I know it's really time to do so. Just why do I suppose that a CCTGA patient at the age of 50 should have an ACP talk? Well, it's, as I said, it's epidemiology. And if you look at the data from Gerhard Diller, from the Brompton, he made a very nice chapter about comparing life expectancy for specific defects with the life expectancy for the general population. And this graph reads as follows. If I have, let's say, a patient with systemic right ventricle and he is 50 years of age, he has the same probability of mortality within the next 5 years as a patient with 67. And I think most of our patients aren't aware of the gap that is between their life expectancy and the life expectancy of the general population. And maybe we just should highlight to them that in the future, they may have to face some kind of tough decisions. So ACP has many components. It just talks about future health expectation. It talks about personal values and goals. It's talk about who could be a healthcare representative, but it also talks about filling out advanced directives or post. It also talks about when do you want your device deactivated, but it's also talk about support for loved ones, and in the end also referral to the palliative care team. And all these topics, I think, they don't need to be addressed at the same time, but they can be addressed in what I call staged approach. So I have to differ if the patient in front of me wants to talk about ACP, but I expect him to live for decades, for years, or for months. And depending on how I anticipate his health deterioration, I address different topics in this patient. So to go into a more concrete example, if I have a patient in front of me with CCTGA, who is approaching 50 years of age, but he's doing well, then just I offer him to talk about what his future health might look like. And I present to him the concept of ACP, and I invite him to such talks, but if he doesn't want, and then it's fine for me. But if he wants to talk about ACP, then I write down what are his goals, what are his values, and I do it usually in an outpatient visit when the patient is still doing fine. If I have a patient in front of me who's doing less well, who needs an ICD, a CRT, or with advanced heart failure, then all the elements of the stage 1 have to be addressed, but we have to do also more comprehensive ACP discussions, going into the nomination of a healthcare representative, advanced directives, and maybe also post. And again, this is actually best done during an outpatient visit. We invite the loved ones to come with him, and it's important that you write down what has been discussed, and we share these documents within the hospitals, but also with other stakeholders. And then in the end, if I have a patient in front of me who I think he lives for weeks to months, be it because the surprise question is positive, be it because he has refractory end-stage heart failure, then really we have to involve the palliative care team. We have to talk about end-of-life preferences, where he wants to die. We have to talk about deactivation of devices. And again, we need collaboration with social workers, with the palliative care team. The patient or the family might need psychological support. And all these issues need to be organized, and this needs time, but it's really helpful for the patient and the loved ones. And what is important is that ACP is a process, and the patient's wishes or the patient's values and preferences may change over time. So this means if anything important occurs, maybe we have to think about re-asking if the plans and goals the patient has formulated a couple of years ago are still valuable, and we have to make sure that we still are actually on the right track. If you want to know or read more about ACP in ACHD, we have published 2 years ago a position paper within the ESC about these topics, and it provides you with much more information than I can give you in this talk. If you are interested, please read it. So thank you very much for your attention.
Thank you very much, Dr. Schwartzman, for such an thought-provoking talk. I have a few questions, but right before, I want to invite the entire panel, as well as all those online, to submit their questions to the chat while we continue our conversation. So Dr. Schwartzman, I think you've raised the question about the right time at the right place for the right talk. And I'm struck by the conflicting statistics that you showed, that nearly 2/3 of patients want to have the advanced care directives talk early, but only 1/3 of physicians want to have that talk. I wonder, are the physicians the right people to have that talk? And I noticed that in your stage 3, you included social worker involvement and collaboration. And I guess my question is, should the allied health professionals be brought in much earlier to assist in these conversations and to guide patient management?
Well, with respect to your first question, who is the right person? I think the ACHD doc is the right person. I think this is kind of responsibility we shouldn't delegate. First, because patients will have questions about health trajectories, and sometimes it really needs the specialist's knowledge a little bit to answer these questions. But of course, these talks doesn't have to be done alone, the ACHD doc with the family. I think if you have support in terms of nursing or line professions, this might be very helpful. But it's really, I think, a doctor's task. And in my experience, it's also a quite rewarding task, because it usually strengthens the patient-physician's bond. Usually we are afraid that we stress the patient by addressing issues he doesn't want to talk about, and he doesn't have the trust in us because we see him dying. But most of the time, patients are really grateful that the doctor addresses such kind of issues. And really, in my experience, it's always to the advantage of the doctor. So I think it's in our responsibility at least to raise the issue and to start the conversation.
And I don't disagree with you. I wonder then, is there things that we can introduce either during training or as continuing medical education that could prepare the doctor to have those conversations? It's often anecdotally conversations I've had with colleagues is that these sort of end of life or even preparation talks are very difficult to be had. And so how do we prepare our colleagues for that?
I think we faced the same situation here in Bern when we decided to start this kind of concept. And I think of course it should be done during university or during the medical studies, but usually there are so many topics that need to be addressed that that talk to patients about advanced care planning are the ones with the least priority. So I think if it isn't done during the study years, then I think it's within our own responsibility. Let's say that there are courses where you can go, usually provided by the palliative care team, and give you just some hints how just to initiate such talks. And usually, if you just know how to initiate and how, if you have some tips what to avoid and what to do, I think this usually is quite helpful for you to get used to it. And I think once you get used to it, it isn't such a magic thing to do this kind of talk. So I think it's just, of course, it should be done during university, but usually you have to do it on your own once you're dealing with patients.
Yeah, it's definitely one of the key competencies that our colleagues need to have. I'm just mindful of the time as well as the chat, and there's a question on the chat actually for Dr. de Groot. And the question is the anatomy of the coronary sinus different in CCTGA, and what are the possible implication and difficulties in CRT implants?
Yeah, that's a very good question. We know from literature and also from our own experience that the, just a moment. Yeah, that's the ostium of the coronary sinus is indeed abnormal. Might not always be the case, but sometimes you have multiple ostia. You can have a stenosis in front of your ostia. It can be at an abnormal location. So these are indeed the challenges you face when you want to implant a CRT device. So that's correct. That might be very difficult to do, and in some cases even impossible.
Just to add to that point, actually, is I think Jeremy Moore's group out of UCLA published literature a couple of years ago about this and showed that, yes, there are very many coronary sinus ostial abnormalities, but that acute successful implantation can be achieved in up to 95%.
Fascinating. Dr. Schwartzman.
I have also a question to Dr. de Groot regarding the results she published from PACES, where you showed that actually CRTs in systemic right ventricle improve functional class, but don't improve ejection fraction. Do you think that this improvement in functional class might just be some kind of placebo effect, and in the end, the CRTs don't help at all?
Yeah, you can't exclude the placebo effect, of course, of a CRT device. On the other hand, you can also think of that the way we measure actually the improvement in ejection fraction is not accurate enough. We all know the major drawbacks of echo, and the patients are not suitable, that you cannot acquire qualities of images enough. So it can be both ways.
I have a question for Lucy. It's a two-pronged question. Lucy, my first part is, in those with kind of advanced heart failure and CCTGA that start to have biventricular dysfunction, and I think kind of further down on that spectrum, what is your group's approach to those with the two ventricle problem? And then the part two to it becomes kind of a flip side as to, do you see instances of myocardial recovery ever, and are there strategies that you guys have to try to assist along in recovery?
Well, thank you. We so the two ventricle thing, so some patients do have LV dysfunction. It generally, when I've noticed it, it's been because they developed pulmonary hypertension secondary to their RV dysfunction. So usually what I would do then, all of these people I would be starting to this for transplant. I don't give any of them any drugs, ACE inhibitors or anything. But I would then diurese them, try and get their PA pressures lower. We sometimes have seen actually good success in people who are ventricularly placed with one ventricle by upgrading to CRT. I know the evidence for it, but anecdotally we would do that. And we have sometimes seen PA pressures come down. And I was wondering if you thought about measuring those, you know, like as a surrogate for doing better. I know the ejection fraction might not change, but maybe the LA pressure comes down. So we do that, and then we try and get them transplanted. If we've only done VADs in 2 patients with CCTGA, but the data suggests that most patients don't need a BiVAD. So if you actually, because you've got a subpulmonary LV, when you fix the loading and you improve the septal function and you get rid of the TR and the pulmonary hypertension, usually the ventricle is good enough with just a subaortic RVAD. So, I mean, I have some experience, but I don't have hundreds of people to tell you about, but that is what we would do as a strategy, what I would do as a strategy. But I would really try and get these people, if they're unwell and both ventricles are failing, my aim is to get them a transplant. The only time I've seen ventricular function improve ever is, bearing in mind I never give anybody any drugs, so I wouldn't have seen it for that, but is only when we've done upgrading people to pacing, like to CRT. That's, and when they've been previously paced in the single ventricle. I have for sure seen that, and I have for sure seen us make people worse by starting pacing them with a single ventricle kind of strategy and then seeing the whole thing go out of whack. So I don't do that.
Lucy, can I ask a quick question? I was quite struck by the survival curve for transplants in the sub-aortic right ventricle. Although it's anecdotal because we have such few patients to follow, what are the results of those supported with a VAD that then go on to transplant? Do you think that they do as well?
That, Ari Cedars has looked at, right, with his in ACHD in general, and I think that they do as well as other patients who are supported with VAD and go on to transplant, you know, non-congenital adults. They do about the same. I don't know in the RVAD, the patients that we've looked after have done very well. Like the ones that we have seen who got a transplant did very well after a VAD. And that's what I hear from the team in Newcastle, that once they get transplanted, they do well. But it's all high risk. They can all not do well. And I could only really echo Marcus. The whole thing needs to be done with a palliative care hat or advanced care planning hat on your head all the time, because it's not the right thing for everybody. And some of these patients have a lot of complications. So when I read the papers, I think, oh, why haven't I done this for this other patient? For instance, I have a 6-year-old right now who's in a palliative care track. And when I think back about the patient, and I have discussed all this VAD and everything, he really couldn't cope with the idea of carrying the thing around, the alarms going off, the anxiety that would cause. It's much more individual about the person that impacts the decision making to me as much as every other thing. But it's not an easy path to go on. So yes, some people do really well. We've had patients have a VAD, she was 100% sensitized, gets a transplant, done amazing, but we've had people do badly as well. And the patient needs to be aware that it might not go well and be able to, and be prepared for that eventuality.
So there's a question in the chat, and I guess it's a nice way to sort of, just given the time, to circle back to the initial case. So it's a two-pronged question, and it's both for Dr. Lynch, Dr. Steed, and Dr. Barron, really. So for the case that was presented earlier, would a VSD closure or tricuspid valve repair be an option prior to PA banding in patients with similar conditions? And then the other question that I had for the trio was, in retrospect, or if we were to see another patient like this again, would there be anything different that we would do in the initial assessment, even prior to our first intervention, that we would consider?
I guess I can start, and then I'll let Dr. Barron and Dr. Steed step in. In answer to the question in the chat, I guess initially, I'm going to point out specifically that this patient actually didn't have tricuspid regurgitation at the outset. That was something that evolved over the course of the interventions that we performed on her. So certainly initially there wouldn't have been an indication for a tricuspid valve repair. Whether that could have been included in one of our subsequent procedures is a separate question. VSD closure, I guess, could have been considered, but cognizant of the fact that she was actually asymptomatic at the time. And the primary reason for the surgical discussion initially was for consideration for a double switch, given her age and size, and determining optimal timing of that. In terms of testing from the outset, I mean, this child, as you will all remember well, we discussed extensively and then went back and did an additional catheter and MRI. So I don't know that there's additional investigations in her case that we could have done prior to intervention that might have changed our decision making. I think the challenge, as Mike alluded to earlier, is how we interpret those investigations in the context of somebody with her anatomy and physiology. She certainly had a volume loaded subpulmonary left ventricle at that point in time. And what we were measuring was a borderline ejection fraction. And I know Mike talked a little bit about the Frank Starling mechanism in someone like her and what impact that has on how we think about the consequences of unloading her ventricle. And those are challenging investigations to interpret. Perhaps we could have done things differently. I know, as Mike said earlier, again, in the next patient we've seen like that, which was actually quite recently, we did band the pulmonary artery, and that patient is currently clinically well, but has not yet gone forward for double switch. I don't know if anyone else has anything to add on those points.
Well, thanks, Anya. I think, no, that's right. It is so difficult. That's why we're spending 2 days discussing these patients. I still don't really understand what physiology we encountered there. And yes, I think you're right. We would probably, with perfect hindsight, have banned it. But I don't know whether if we'd then gone on and double switched, we'd have encountered the same problems. And as you say, probably, you could argue VSD closure alone would be the simplest option there. But all the data that we've looked at over the last 2 days has shown you that as she did have, although she didn't have any TR, she had far from normal systemic RV function. And we know that physiological repair, by which we mean simply VSD closure, in those patients has a very disappointing outcome. So, it's difficult to know if we should have done something different. That I think, all the data would tell us, no, we shouldn't. We should still pursue anatomic repair in these sort of patients, but of course, this goes to show you don't always get it right, and it's still a bit perplexing.
Mike, you had your hand up.
Yeah, I mean, I'd recall that the patient's own cardiologist from the outside centre had suggested that we consider a physiologic repair in this patient, and we had convinced him that we should do an anatomic repair. So yeah, again, difficult to know what would have happened in that setting. I guess another thing we don't know is about her myocardium. She certainly had been volume loaded for a long time with a very big shunt. We know that fibrosis does develop in that setting. Usually we get away with it, when we repair those sort of shunts, but it's possible that we'll ultimately find that she had a lot of fibrosis in her heart. I don't know.
I was wondering, particularly given some of the earlier talks yesterday, whether there is a role for example, pressure volume curves to see how much reserve there is to the myocardium, because clearly it's completely different from using it in the setting of a completely septated heart and retraining the left ventricle. But I do wonder if it would have unmasked some fragility that we were missing.
Yeah, I mean, I don't have much experience of that myself. And I guess the discussions that we had about pressure volume loops was much more in the setting of, retraining the left ventricle when there's an intact ventricular septum. So I don't know if there's any data available about that, but and how easy it is to do pressure volume loops in the setting of a large VSD. Yeah, one of the things that David has introduced us to is the concept of doing sort of dobutamine stress testing in patients that you've got, where you're trying to retrain the left ventricle. And I guess, seeing a ventricle respond to dobutamine, you know, the increased cardiac output and so on that you induce, a sort of increase in afterload on the LV, if you like, where the banded with a banded pulmonary artery. If you see the ventricle, you know, develop more pressure in that setting, that can be reassuring that they're going to be okay when you do the double switch.
But of course, in this particular case, we knew the ventricle was performing at systemic pressure because of that large VSD. So you kind of take it for granted that the ventricle is trained.
Well, this has been a fantastic session. I think all the speakers have done a great job, and I think the case really helped to set the stage for really excellent questions and discussion. And so, being mindful for the time, we're just wanting to thank everyone for the talks, and we'll keep this part of the agenda moving. And I believe it's break time, right, Mike?
That's right. It's lunchtime for us. In other places, it may be dinner time, I suppose. But we will basically break for about half an hour now, perhaps slightly shorter now, and start again with future directions at 1:05 Toronto time.